Hi, a very good afternoon to all of you. So, am I audible and visible? Let me know if I am audible and visible to you. Just show me a thumbs up. I will continue where I left yesterday. And I hope all of you have gone through. Hi, a very good afternoon to all of you. I hope you've gone through the PDF which I had sent on my Telegram. So all these questions are from that PDF itself. No new questions have been added because they are from the past 4 years. Only thing is at a few places I have added a few explanations which you will add while you are attending this class. You are going to note down those extra points which I have added now after I had sent the PDF to you, right? So we had done yesterday all questions up till bleeding in early pregnancy, where I had taught you about ectopic we have done, about abortions we have done, and about molar pregnancy. Now, in the past few years, the questions which have come on antepartum hemorrhage. So they had given this image into 2019. This question came in 2019. They had given this image and they had asked you which type of placenta is this, right? So over here, what you can see, over here you can see that this is the internal os and the placenta is covering the internal os partially. Now, because the placenta is covering the internal os partially, that is why I will call it as type 3 placenta previa. So this classification, although it is no longer used, still you will have to remember this classification: type 1, type 2, type 3 and type 4. I'm sure you know type 1 means where the lower edge of the placenta lies within 2 centimeters of the os. Type 1 is also called as lateral placenta previa. Then if the margins of the placenta if the placenta touches the margins of the internal os, that is type 2. If placenta covers the internal os incompletely, that's type 3, and if it covers it completely, that's type 4. Type 1 is also called as lateral, type 2 is marginal, type 3 is incomplete, type 4 is complete placenta previa, or it is called as central placenta previa. Right now, what I want you to know is the new classification. According to the new classification, there are only two categories. We don't have type 1, type 2, type 3, type 4 anymore. It is placenta previa and low-lying placenta. So the earlier type 2, type 3, type 4, they come under placenta previa. And the earlier type 1, which was when the placenta was within 2 centimeters of the os, but it was not touching it, that comes under low-lying placenta, right? So the पुराने क्लासिफिकेशन में whatever was type 1 is now called as low lying, and type 2, type 3 and type 4 are now collectively called as placenta previa according to the new classification. Right now, another very important thing which I want you to understand is all of you know how to manage a case of placenta previa when a patient comes to you with bleeding. So you have to either go for expectant management, that is McAfee and Johnson regime, or you have to go for active management. But what if there is a placenta previa and patient doesn't have any bleeding? Patient ko koi bleeding nahi hui, she is a case of placenta previa. So remember that for diagnosing placenta previa, you have to do an ultrasound at 32 weeks. So suppose in the first trimester or in the second trimester, you see that the placenta is low lying, still you are not going to call it as placenta previa unless and until you confirm that it is a case of placenta previa at 32 weeks by doing a TVS. The investigation of choice for placenta previa is TVS, although per vaginal examination is contraindicated. So I am going to do a TVS at 32 weeks. And I am going to repeat it at 36 weeks. अब 32 weeks का ultrasound भी हमें बता रहा है कि this is a case of placenta previa or low-lying placenta, and 36 weeks का ultrasound is still confirming that it is a case of placenta previa or low-lying placenta, but the patient doesn't have any bleeding. In this situation, what are you expected to do? In this situation, you are expected to perform an elective cesarean section between 36 to 37 weeks plus 6 days. So between 36 to 37 weeks, you have to schedule a cesarean section. Always and always, for delivering placenta previa or a low-lying placenta, the best mode of delivery always is going to be cesarean section. Clear to all of you? Yes? Okay. So this was the question which they had asked on placenta previa in the past 4 years in NEET. Now comes what question was asked on puerperium. So in puerperium, 2 to 3 topics were asked in past 4 years. One was they had asked a question on the treatment of mastitis in a lactating female, right? So in a lactating female, someone has written, is low-lying placenta previa same? Yes. So low-lying placenta ka management and placenta previa's management is same, right? Now, what is the line of treatment of mastitis in a lactating mother? So remember that the drug of choice for mastitis in a lactating mother is what? Tell me. A, B, C or D. What is the drug of choice? Dicloxacillin. It is option A, right? Now, mastitis usually it occurs in 3 to 4 weeks postpartum period. Most commonly it happens when a mother has cracked nipples. A patient with mastitis is going to come to you with complaint of pain, fever, chills, and her breast may be hard and red. Most of the times, 90% of the times, mastitis is unilateral, and the most common organism which can lead to mastitis is Staph aureus. Drug of choice is dicloxacillin, which you have to give for 10 days. If patient is penicillin sensitive, and she has some sensitivity to penicillin, in that case you are going to give erythromycin. Suppose if Staph aureus is resistant to penicillin, then the drug of choice is vancomycin. Breastfeeding should be continued in case of mastitis. Remember, in developing countries like India, breastfeeding is also continued in HIV, right? So in HIV also breastfeeding is not contraindicated. So in country like India, there are only very few contraindications for breastfeeding. One of the contraindications for breastfeeding is if baby is lactose intolerant, or they have galactosemia, or if mother, she is an IV drug abuser, then in that case you don't have to breastfeed. Or if there is active herpes lesion which is present on the breast, then in that case the mother doesn't have to breastfeed. Or if mother was on any chemotherapeutic drug. So this was one of the questions which was asked in foreign medical graduate exams, and since it is the same body which prepares the question, so remember what are the contraindications for breastfeeding. No, please remember, if the report is showing low-lying placenta type 2, you are not going to go for vaginal delivery. In placenta previa, it has to be cesarean section, right? Okay. Yeah, so I told you, NEET PG, I told you, if the mother is on anti-cancerous drug, on a chemotherapeutic drug, then it is a contraindication for breastfeeding, right? Then, next question was, a 22-year-old pregnant lady presents with fever and is put on antibiotics. Fever is still not brought under control. On further investigations, she is having septic pelvic thrombophlebitis. Which of the following is the next course of action? Yeah, chemotherapy, radiotherapy, both are contraindications. Now, septic pelvic thrombophlebitis, when it happens, then most of the times we have seen it will involve one or both ovarian plexus. Symptoms of septic pelvic thrombophlebitis are mother is going to have chills, fever with chills. Occasionally she may have a lower quadrant pain. Management of septic pelvic thrombophlebitis is basically antibiotics, but if fever is not resolving, then in that case, to prevent thrombosis from happening, you are going to give antibiotics plus heparin. So the management is antibiotics and heparin. You are not going to stop antibiotics, right? You are not going to stop giving her antibiotics. It is antibiotics and that is antibiotics and heparin, right? So the septic pelvic thrombophlebitis, कोई और question बन ही नहीं सकता in septic pelvic thrombophlebitis except this, the management of septic pelvic thrombophlebitis. The other thing is that these days, the studies are going on which have shown very controversial results of heparin. So these days, some guidelines say that along with antibiotics, you may use heparin. Some may say you shouldn't be using heparin. As of now, we are sticking to it that in case of septic pelvic thrombophlebitis, if the fever is not resolving, you have to give antibiotics and you have to give her heparin, right? Best drug for hypertension in pregnancy. As I told you yesterday, that now there is no concept like best drug for hypertension in pregnancy. Now it is first line drugs for hypertension in pregnancy, whether it is severe preeclampsia or whether it is chronic hypertension. It is first line drugs. There is no best drug. But suppose by chance the examiner has taken question from previous year papers, right, when there was a best drug, then the best drug for severe preeclampsia was definitely labetalol, and for chronic hypertension also it was labetalol, but it was then changed to alpha methyl dopa. So initially it was labetalol, then it got changed to alpha methyl dopa. Now the recent guidelines, recent Williams jo kehta hai, wo kehta hai there is no drug of choice. There is always first line drugs, and first line drugs I have told you what they are, right? So I can also share with you the page of the Williams where it has written that now there is no drug of choice, there are first line drugs. Okay. Now what will be the level of uterus on second day post delivery? Now for this, please remember that immediately after delivery, uterus is at the level of the umbilicus, just below the umbilicus. That is where uterus is, and it has consistency of a cricket ball. Now till 24 hours after delivery, there is no involution which is going to happen in the uterus. After 24 hours of delivery, the height of the uterus will decrease by 1 centimeter per day. That is 1 finger breadth per day. That is after 24 hours, the height of the uterus will be, decreasing by 1 centimeter per day, right? So now suppose they ask you what will be the level of the uterus on second day post delivery. On second day, the height of the uterus, till 24 hours, the height of the uterus will not decrease. Now after 24 hours, the height of the uterus is going to decrease, and it will decrease by 1 finger breadth, right? So it is going to be option A, that is 1 finger breadth below the umbilicus. Now the other thing which you have to remember is, after 1 week of delivery, uterus is midway between umbilicus and pubic symphysis. After 2 weeks, it is not palpable, and by 4 weeks, involution is complete. As far as weight of the uterus is concerned, immediately after delivery, weight of the uterus is 1000 grams. After 1 week, it is 500 grams. After 2 weeks, it is 300 grams. And by 4 weeks, it is 100 grams. Right? So remember that involution is complete by 4 weeks. This is the exact timing which is given in Williams, and you have to remember 4 weeks. Gone are the days when we say that involution of the uterus is completed by 6 weeks. No. It is specifically mentioned in Williams that involution is completed by 4 weeks. Then maximum dose of PGF2 alpha. So now we have to, that these were the questions which they had asked on puerperium. Coming to questions which were asked on PPH in the previous few years. Maximum dose of PGF2 alpha in PPH. Now remember, dosages of all the drugs which are used for AMTSL and for managing PPH is very, very important, right? So as far as PGF2 alpha is concerned, which is Carboprost, or which is also called as Gynoprost or Hembate, it is never used for managing active management of third stage of labor. So it is not used in active management of third stage of labor. It is the best drug to treat PPH. But the first drug which you are going to use will be oxytocin, because that is the uterotonic which is recommended by WHO to treat as well as to prevent PPH. That means for active management of third stage of labor. Now for Carboprost, remember, for active management of third stage of labor, you never use Carboprost. You use it only for treating PPH, and you have to give 250 micrograms IM. You can repeat this dose after every 15 to 90 minutes, and maximum you can repeat it up till 8 doses, that is 2 milligrams. And that was a pretty easy question. which was asked by NEET, that it is 2 milligrams, right? I want you to quickly revise all these doses. The dose of oxytocin for a AMTSL is 10 international units. Oxytocin should always be given as IM or as IV infusion, never as IV bolus, because if you give oxytocin as IV bolus, it can lead to hypotension and cardiac arrest. It can lead to hypotension and cardiac arrest. Now, PPH में dose of oxytocin is 20 international units. Methyl ergometrin की dose is 0.2 mg. You can repeat it after every 2 to 4 hourly in case of PPH. Misoprost PGE1. The dose for active management is 400 micrograms. Now the new recommendations are 400 to 600 micrograms. And PPH में the WHO says 800 micrograms. ACOG says 600 to 1000 micrograms, right? Sorry, what have I written? It's not international units, sorry, it is micrograms. 1 second. 400 to 600 micrograms. It's not international units, right? WHO says 800 micrograms and ACOG says 600 to 1000 micrograms. Is this clear to all of you? Now, WHO कहता है कि for managing PPH, you can give it orally, you can give it sublingually, but it never says that you can give it per rectally. ACOG कहता है कि for managing PPH, misoprost can be given per rectally as well. Right? Clear to all of you? So this is the difference between misoprost dose recommended by WHO and ACOG in PPH. If they do not ask you whether if they do not mention in the question whether they are asking about ACOG or whether they are asking about WHO, you have to tell the dose recommended by WHO, that is 800 micrograms. You are going to mention 600 to 1000 only if they ask you about the dose recommended by ACOG, right? Carbetocin is, what is carbetocin? It is synthetic oxytocin. Carbetocin is a drug which is used for active management of third stage of labor. It is not used for managing PPH. And please do not get confused between carbetocin and carboprost. Carbetocin is used for AMTSL, Carboprost is used for PPH. Carbetocin की dose होती है 100 micrograms slow IV. Tranexa is also recommended by WHO for treating PPH and its dose is 1 gram in 100 ml of normal saline, which is given over 10 to 20 minutes. So 1 gram in 100 ml of normal saline. Carbetocin ki dose has also been asked many times along with misoprost dose and carboprost dose, right? So all these dosages are very, very important. You are going to tell me in which condition is carboprost contraindicated. Carboprost is contraindicated in case of bronchial asthma and if there is suspected amniotic fluid embolism, then carboprost is contraindicated, right? In which conditions is methyl ergometrin contraindicated? Methyl ergometrin is contraindicated if you are a Maro subscriber or if you are my student of GSOG classes, you know the mnemonic TOPER. So in TOPER conditions, methyl ergometrin is contraindicated. Yes, and in pulmonary hypertension, thank you Shubham for reminding me, carboprost is also contraindicated in pulmonary hypertension. So there are 3 conditions where carboprost is contraindicated: bronchial asthma, pulmonary hypertension, and in case of suspected amniotic fluid embolism. Excellent. A female patient after normal vaginal delivery developed atonic PPH. She was shifted to OT and the obstetrician planned to ligate the vessels to arrest bleeding. What is the order of ligation of vessels? And I'm sure you all know this question. So all those arteries which supply the uterus, you are going to ligate them. First, you are going to ligate uterine artery. Then you are going to ligate the anastomotic branch of ovarian artery. And still if bleeding continues, then you have to go ahead with ligation of the internal iliac artery. Why internal iliac artery? Because uterine artery is a branch of the anterior division of internal iliac artery. Please remember, you have to ligate only the anterior division and not the posterior division, and that is why you have to ligate 5 centimeters below the bifurcation of the common iliac artery into internal and external iliac artery. So what is the point for ligation of internal iliac artery? 5 centimeters below the bifurcation of common iliac artery. Quickly, let us revise the protocol for managing PPH. So number one, when a patient comes to you with PPH, you are going to do a uterine massage. The first step which you do is a uterine massage, right? And you confirm that you are dealing with a case of atonic PPH. How do you confirm that you are dealing with a case of atonic PPH? By doing a per abdominal examination and a per vaginal examination, right? I'll tell you topper's abbreviation just now, just hold on. So, uterine massage karoge, per abdominally you are going to do a uterine massage, and also you are going to do a per vaginal examination, and you will be sure that you are dealing with atonic PPH. Once you are sure you are dealing with atonic PPH, you will continue the uterine massage and you are going to give uterotonics. And along with uterotonics, you are going to give injection Tranexa, right? So, uterotonics plus injection Tranexa, right, and uterine massage. All these three things you are going to continue for half an hour. If the bleeding doesn't resolve, then you go to mechanical methods like Bakri balloon catheter. And still, if bleeding persists, then in that case you are going to see whether the vitals of your patient are stable or unstable. If vitals of your patient are stable, then in that case you are going to go for either uterine artery embolization or you can go for compression sutures, right? And if vitals of your patient are unstable, then you are going to go for devascularization surgery. In devascularization surgery, you are going to ligate uterine artery, you are going to ligate the ovarian artery, and you are going to check the vitals of the patient. Now, if the bleeding continues and vitals of your patient are stable, go ahead with ligation of anterior division of internal iliac artery. But if the vitals of the patient are unstable, right, then in that case, do not go ahead with ligation of the internal iliac artery, because that is going to take some time and your patient's vitals are unstable. Quickly go for subtotal hysterectomy. Okay, now comes your queries. So there are 3 queries which I'm getting. One is topper's abbreviation, another is about Shubham, I have just now corrected it. That is a mistake there. If in edition 6 it has gone like this, please correct it. It is 1 finger breadth. Please correct this. If by mistake in edition 6 it has gone as 2 finger breadth, please correct it as 1 finger breadth. So, Sejal said, do we include uterine massage in AMTSL tried for PPH? Okay, now let me come to your queries quickly. So, TOPER. T stands for after the delivery of first twin. Methyl ergometrin is contraindicated. O stands for any organic heart disease, in other words, any heart disease. Pre stands for preeclampsia. E stands for eclampsia, and R stands for RH negative pregnant females. Now, in RH negative pregnant females, अगर ओवरऑल पूछें RH negative pregnant females में क्या करते हैं, you are going to say normally in RH negative pregnant females, which type of cording of clamp are you going to do? Early cord clamping or delayed cord clamping? Normally in RH negative females, if the blanket question comes, you say we do early cord clamping. But agar typically पूछा जाए, particularly पूछा जाए that in an RH negative pregnant female, indirect Coombs test is negative, indirect Coombs test is positive. ऐसे question आए, then in indirect Coombs test negative, you go for early cord clamping. In indirect Coombs test positive, you go for delayed cord clamping. Overall blanket question आए, नहीं दिया indirect Coombs test के बारे में anything, then you are going to say in RH negative, we go for early cord clamping. So these are all contraindications for methyl ergometrin. This is one query which I have answered. Okay, now comes the second query. about uterine massage. See, uterine massage earlier was a part of active management of third stage of labor. Now WHO has removed it from active management of third stage of labor, and now it has put it in treatment of PPH. So earlier uterine massage was the fourth step in active management of third stage of labor. First step in active management of third stage of labor was giving a uterotonic. Second step was your delayed cord clamping. Third step was delivery of the placenta by controlled cord traction. And fourth step was uterine massage. Now they say instead of uterine massage, it is intermittent assessment of uterine tone. Right? And uterine massage ko from active management of third stage of labor se hata ke, they have put it in management of PPH. But suppose you are getting a question which so many times you have got. The question is, all of the following are included. All of the following are included in AMTSL except. Right? And your options are early cord clamping, uterine massage, delivery of placenta by controlled cord traction, and one more option is uterotonic, injection uterotonic. Right? Now tell me, what is your answer going to be? Tell me, what is your answer going to be? A, B, C or D? Which of the following is not included? So all are included except. So whenever you get a question like this in except, you are going to mark the answer as early cord clamping, because early cord clamping is never a part of AMTSL. At least uterine massage was earlier a part of AMTSL. Now suppose instead of this option, now you have options like these. Now the option changes, and option A is delayed cord clamping, uterine massage, delivery of the placenta by controlled cord traction, and uterotonic. Tell me. Now your answer is going to be? Now your answer is going to be option B. Why option B? Because yes, delayed cord clamping is a part of AMTSL, delivery of the placenta by CCT is a part, and uterotonic is a part. Right? Now suppose, now your option changes and they say delivery of placenta by Crede's method. Now tell me, what is your answer going to be? Now tell, A, B, C or D? Please remember, delivery of placenta by Crede's method is never done in AMTSL. Right? So now your answer is going to be option C. देखो, यूट्राइन मसाज करने से कभी भी कोई प्रॉब्लम नहीं होगी, ना तो मदर को प्रॉब्लम होगी, ना न्यूबॉर्न बेबी को प्रॉब्लम होगी. अर्ली कॉर्ड क्लैंपिंग करने से बेबी को प्रॉब्लम होगी बिकॉज ऑफ फीटल, द बेबी माइट डेवलप फीटल neonatal anemia. Crede's method is a very crude method of delivering placenta. It is never done. इससे mother को problem होती है. Uterine massage is a thing which can never cause problem to the mother, neither it can cause problem to the baby. Rather, uterine massage करने से just in case mother को PPH हो गया, so you are doing the first step in management, right? So over B and C, if I have to choose, I am going to say that uterine massage can be included in AMTSL, but delivery of the placenta by Crede's method can never be included in AMTSL. Clear to all of you? Yes? Okay, now tell me, which uterotonic is contraindicated in hypertensive females? Which uterotonic you are not going to give in hypertensive females? Which uterotonic you are never going to give in hypertonic females? Methyl ergometrin. You will never give methyl ergometrin to hypertensive females, right? So methyl ergometrin is contraindicated in hypertensive females. Coming to the next topic, that is third stage complications. Now, a female patient collapses soon after delivery. There is hypotensive hypoxia and features of DIC. Which of the following is the most likely etiology? Amniotic fluid embolism, PPH, peripartum cardiomyopathy, or rupture of the uterus? Tell me. Now, let us understand this question first. So, first of all, can it be rupture of the uterus? See, if uterus is rupturing, right, so there has to be previous history of cesarean section, because of which there is uterine rupture, right? So, uterus, an intact uterus without any previous scar, without mentioning कि उस uterus पे कोई scar था, uterus will not rupture like this, right? So, it cannot be rupture of uterus. Coming to peripartum cardiomyopathy, what do you get in peripartum cardiomyopathy? In peripartum cardiomyopathy, patient is going to have heart failure, and this heart failure happens in an absolutely normal female who did not have any previous heart disease between 35 weeks of pregnancy to 5th month postpartum, right? But in peripartum cardiomyopathy, you will never get features of DIC. So, peripartum cardiomyopathy ruled out. You are going to get heart failure, but you are not going to get DIC, right? Now comes a choice between amniotic fluid embolism and postpartum hemorrhage. Please remember that whenever you are getting hypotensive hypoxia, whenever the word respiratory difficulty in breathing or hypoxia is there, so hypoxia means there will be difficulty in breathing. कभी भी क्वेश्चन हो पोस्टपार्टम कोलैप्स का एंड क्वेश्चन में दिया हो दैट देयर इज कार्डियो रेस्पिरेटरी फेलियर, it has to be amniotic fluid embolism. In case of amniotic fluid embolism, the disease happens in two phases. Number one, in the first phase, patient has cardiac plus respiratory failure, what they have given us as hypotensive hypoxia. And if patient survives this first phase, then in the second phase, she is going to have DIC. So, क्वेश्चन में कभी भी दिया हो breathlessness, difficulty in breathing, hypoxia, all that is pointing towards respiratory failure. Now they are saying hypotensive, which means yes, there is cardiac failure also, and they are telling you there are features of DIC, so it has to be amniotic fluid embolism. Okay, now you are asking me, abhi ruk jao. Just let me tell you, first let me explain this question, then I'll tell you that why in Rh negative female with indirect Coombs test delayed cord clamping. So first let me explain this. Right now, this is one of the very hot topics which is there, that is obstetrical emergencies, jisme you have to find out whether you are dealing with postpartum collapse mein, whether it is PPH, whether it is amniotic fluid embolism, or whether it is uterine inversion. So over here, I have made a table for you which is going to help you in making the diagnosis of these conditions. Jab bhi question aayega, whenever you get a question on postpartum collapse or postpartum shock, these are the three main differential diagnoses which you have to keep in mind. In case of PPH, the question is going to say that patient had excessive bleeding and then the patient went into shock. In case of uterine inversion, question is going to say patient went into shock immediately after delivery. right? So the word immediate is going to there. Immediately after delivery, patient went into shock. In case of amniotic fluid embolism, you are going to get a very typical history where initially patient is going to have respiratory failure and heart failure. So there are going to be words like difficulty in breathing, breathlessness, hypoxia, and patient will be in shock. If patient survives this phase, then she goes into DIC. So initially जो bleeding होती है, that is less. Initially, in amniotic fluid embolism, the shock and bleeding are out of proportion to each other. Same is the case of uterine inversion. In uterine inversion, initially shock is neurogenic. Patient goes into shock immediately after delivery because of because when the uterus inverts, then it leads to neurogenic shock, and later on there is excessive bleeding due to hemorrhagic shock. So initially the shock and bleeding are out of proportion to each other, right? But in case of PPH, excessive bleeding hogi and then patient is going to go into shock. That is one difference between them. Second difference you can come to note on per abdominal examination. Now, in case of PPH, the most common variety of PPH is atonic PPH. So, the tone of the uterus will be decreased. And जब हम massage करेंगे, when you will be massaging the uterus, the tone will increase. But when you will stop massaging, again the tone will decrease. In case of uterine inversion, you will feel a cup-like depression just below the umbilicus because the fundus of the uterus has inverted, so you are going to get a cup-like depression just below the umbilicus. In case of amniotic fluid embolism, uterus will be absolutely normal. The tone of the uterus will also be absolutely normal. Then comes finding per vaginal examination findings. In per vaginal examination, in case of PPH, you will get excessive bleeding. In case of uterine inversion, you will feel a globular mass. So the fundus of the uterus can be felt. So you are going to feel a globular structure inside the vagina. And in case of amniotic fluid embolism, per vaginal findings will be normal. So in case of amniotic fluid embolism, question can come in two ways. Agar question first phase pe aa raha hai, so question is going to say patient was having respiratory difficulty in breathing, breathlessness, and patient was in shock and the bleeding was less. But if patient goes into second phase, then patient is going to have excessive bleeding. Right? So based on bleeding, हम ये नहीं कहते कि amniotic fluid embolism की diagnosis है कि नहीं है. We are going to make a diagnosis of amniotic fluid embolism based on this, that initially there is, in the first phase there is going to be respiratory failure and cardiac failure, and in the second phase there is going to be DIC. Clear to all of you? Yes. So this is over here. Now, because they have clearly mentioned hypotensive hypoxia and features of DIC, so I am going to choose the answer as amniotic fluid embolism. Clear? Now, someone has asked me how to differentiate in images between uterine inversion and between prolapse. So, when there is going to be uterine inversion, it is the fundus of the uterus which is going to come out. So, if you see a mass which is hanging out from vulva and you cannot see the os, that means it is an image of inversion. In case of prolapse, it is the uterus along with the cervix which is coming out. It is not the fundus which is coming out, right? So in case of prolapse, you are going to see uterus and you will see the os also there. So if os is visible in images, it is a case of prolapse. If os is not visible, it is a case of uterine inversion. Clear to all of you? Now comes the next question which you have asked me, and that is, why in RH negative females, if indirect Coombs test is negative and if indirect Coombs test is positive, there are different ways of cord clamping. Indirect Coombs test negative, what does that mean? It means that just now the fetal blood has not entered the mother's blood and mother's blood ने अभी antibodies नहीं बनाई हैं against the fetal RH antigen. That is what is meant by indirect Coombs test negative. right? So if indirect comb test is negative, I will do early cord clamping so that during this phase also, when the delivery is happening, fetal blood doesn't enter the mother's blood and it does not lead to production of antibodies against Rh antigen, right? But suppose indirect comb test is positive. What does that mean? Indirect comb test positive का मतलब है already fetal blood has entered into mother's blood and it has stimulated mother's blood. Now mother's blood में already antibodies have been formed against fetal Rh antigen. So if antibodies have already been formed, why should I go for early cord clamping? Rather do a delayed cord clamping and at least baby को anemia से बचा दो. Clear? So that is why if indirect comb test is positive, delayed cord clamping. If indirect comb test is negative, early cord clamping. Now comes another question, that why is Carboprost not used in prevention of PPH? Because Carboprost is a very, very good drug. It is a very strong drug and WHO has reserved this drug for management of PPH rather than for a prevention of PPH. Similarly, studies have shown that carbetocin can prevent PPH, but it is not that effective in treating PPH. So unnecessarily you will be wasting that golden hour time which you have by using carbetocin and not using Carboprost. So that is, they are very clear. Carbetocin is for AMTSL and Carboprost is for management of PPH. Okay. So in the PDF which I had shared with you yesterday, this is there, the diagnostic criteria for amniotic fluid embolism. I want all of you to go through it very carefully. This is one of the very hot topics these days, amniotic fluid embolism, uterine inversion and PPH. Then questions which have been asked on labor malpresentation and partogram. In partogram, I want all of you to know about labor care guide also. So before your INI set, which happened in November or December, I had taken a session where I had told you all updates. So I want all of you to please go and watch that session. That session is still on my YouTube channel. It has all updates which you need to know, whether the update is regarding semen analysis or whether the update is regarding the new partogram. Everything is there. I want you to go and watch it. Which of the following is seen in vertex presentation with complete flexion attitude of the head? Now, if you are my student from Marrow or from GSOG classes, I always tell you, if the head of the baby is completely flexed, right? Have you seen babies crying? जब बच्चे रोते हैं, they cry like this. They flex their head and then they cry. What is the other name for crying? The other name for crying is sobbing. So when the head of the baby is completely flexed, the diameter which you see is SOB, suboccipito-brachmatic diameter, which is 9.5 centimeters. Right? Okay. Now, vertex presentation is also seen when the head of the baby is deflexed, and when head of the baby is deflexed, then the diameters which come into play are occipitofrontal diameter or suboccipitofrontal diameter. Right? Then in bro presentation, the head of the baby is partially extended. Then you get bro presentation. In bro presentation, the diameter which comes into play is mentovertical diameter, which is the largest AP diameter. And that is why in bro always you have to do a cesarean section. And in case of face, the face presentation you get when head of the baby is fully extended, and in case of face, the diameters which come into play are submentovertical or submentobrachmatic diameter. Now tell me, what is that maneuver which you do during normal vaginal delivery so that it is the smallest diameter which comes out first? So that is something where you initially flex the head of the baby and then extend it and you support the perineum. What is that maneuver called as? So during delivery of fetal head in the second stage, what maneuver do you do? Quickly, what is the maneuver which you do? Excellent, Kush. It is Retrogen Maneuver, right? What are the methods by which WHO recommends to prevent perineal tear? So WHO says to prevent perineal tear, what do you should do? There are 3-4 things which you should do. Number 1, you can give a perineal massage. Number 2, you can put a warm compress at the perineum. Number 3, you can support the perineum. And number 4, initially you are going to flex the head of the baby and then you are going to extend, right? So these are the steps which you do to prevent perineal tear in second stage of labor. Now, what are the steps which WHO does not recommend? So WHO does not recommend routine episiotomy and WHO does not recommend fundal pressure, right? Okay. Next question. A primigravida presents to you in labor room at 40 weeks of gestation with lower abdominal pain. She has been in labor for 3 hours, right? And which of the following will determine if she is in active labor? So fetal head 5 by 5 palpable per abdominally. If head of the fetus is 5 by 5 palpable per abdominally, that means that head is not yet engaged, right? And engagement is something which is necessary to say that yes, there is active labor. So head of the baby, if it is 5 by 5 palpable, it means the head of the baby is still floating. Engagement कब कहते हैं? Engagement हम तब कहते हैं when head of the baby is less than equal to 2 by 5th palpable per abdominally or per vaginally if head of the baby is at ischial spine, that is at 0 station. So it cannot be this. If head is 5 by 5 palpable per abdominally, patient is not in active labor. If she is getting 2 contractions for 10 seconds in 10 minutes, again she is not in active labor, because for adequate contractions, the definition is it has to be 3 contractions in 10 minutes, 3 or more than 3 contractions in 10 minutes, each lasting for 45 seconds and increasing the pressure by 65 to 75 millimeters of mercury, right? Then more than 5 centimeters dilatation with complete effacement, yes. Please remember these 2 things about latent phase and active phase. ACOG guidelines and the new WHO guidelines. According to ACOG guidelines, latent phase is up till 5 centimeters and from 6 centimeters begins active phase. And this is the one which we are using clinically also, कि 6 centimeters se active phase begins, right? Now, new WHO guidelines say कि latent phase is up till 4 centimeters and active phase begins at 5 centimeters. This is the reason why that the new partogram which is now there, and what is this new partogram called as? Labor Care Guide. Labor Care Guide. So in Labor Care Guide, your markings are going to begin from 5 centimeters. Right, because according to the new WHO guidelines, active phase begins at 5 centimeters, right? Now, rupture of membranes, again, that does not necessarily happen in active phase. Rupture of membranes, if it is happening before the commencement of labor and after 37 weeks, that is what is called as PROM. If it is happening at more than 37 weeks but before the onset of labor, that is PROM. If it is happening at less than 37 weeks, it is PPROM. Clear to all of you? So this is rupture of membranes does not mean active phase always. So the answer to this question was option C. Coming to the next question. Again, this was NEET 2022 question. You are examining a multigravida female in second stage of labor for past 2 hours. On examination, contractions are adequate. So she has been in second stage of labor for 2 hours. Cervix is dilated. Head of the baby is at 0 station. Caput is present. Molding is present. Sagittal suture is in right occipito-transverse position. So sagittal suture of the baby is in ROT position. Right, the fetal heart rate is 140 per minute. Which of the following is carried out for management of this patient? So, सबसे पहले let us discuss don't worry about this situation. First, let us see if any multigravida female is in second stage of labor for 2 hours. Is it normal or is it abnormal? Right? So average duration of the second stage of labor in a nulliparous or a primigravida female is approximately 1 hour. In multiparous, it is 30 minutes. Maximum, it can be 2 hours in nulliparous females or 1 hour in multiparous females. And we say that arrest has happened when it is 3 hours in primigravida females or 2 hours in multigravida females. Right? Now, this means that if your patient is multigravida and she is in second stage of labor for 2 hours, this is not normal, right? This means either there is a second stage arrest or the second stage has got prolonged. Clear? Now, how am I going to manage this? So this means I have to do some intervention. Right? Now, the interventions which can come to your mind are, number one, you can think about instrumental delivery like vacuum or forceps. Why you can think about vacuum or forceps? Because the cervix is fully dilated, and vacuum and forceps, they can be applied only if the cervix is fully dilated. Right? Or you may go for cesarean section. This is clear to you. Now, how am I going to choose between the three? Understand a few basic things about vacuum and forceps. Vacuum and forceps, number one, they can be applied only when the cervix is fully dilated, although vacuum can be applied when the cervix is 6 centimeters or more dilated. But हम prefer करते हैं vacuum को apply करना only when cervix is fully dilated. Number two, vacuum and forceps can be applied only when the head of the baby is more than equal to +2 station. So either the head of the fetus is at +2 station or below it. Then only you can apply vacuum or forceps. Right? Third thing which you should remember is forceps cannot rotate the fetal head. Forceps can be applied only if sagittal suture of the fetal head is in AP diameter, that means it is in DOA position, or if it is in LOT position or ROT position, that means maximum 45-degree deflection is there. So forceps cannot rotate the head of the baby. You can apply forceps only and only if sagittal suture is in AP diameter or maximum it is 45 degrees deflected. In other words, head of the baby or the sagittal suture is in LOT position or in ROT position. But vacuum can rotate the head of the baby. Right? So keeping all this in mind, let us see the question again. Now question is saying that the head of the fetus is at 0 station. Now, because head of the baby is at 0 station, can I apply vacuum? No. Can I apply forceps? No. Because forceps and vacuum can be applied only and only if station is more than equal to +2. Right? The other thing which they have given is that sagittal suture is in ROT position. तो जैसे ही उन्होंने कहा sagittal suture is in ROT position, forceps तो वैसे ही out है. You cannot apply forceps even if the station would have been +2. Right? So now I am changing this question for you. I am saying that station is +2. Now if station is +2 and head of the baby is in ROT position, still my answer will not be forceps. Right? Now I have to choose between vacuum and cesarean, and still I am going to choose cesarean. Why? Because they have given one more thing, and that is molding and caput. Right? Molding and caput. Whenever these two terms are present, that molding is present and caput is present, both of them are present, it indicates cephalopelvic disproportion and you have to do a cesarean section. Are you understanding? So please understand, read your questions very carefully. Molding and caput, dono if they have given you together, it means it's pointing towards CPD, and whenever there is CPD, you cannot apply vacuum or forceps. Vacuum and forceps cannot be applied in cephalopelvic disproportion. You have to do cesarean section. Clear to all of you? Now, suppose your question says, SI question I, and your question says that when there was this female, a primigravida or a multigravida female, was in second stage of labor for 2 hours, and on per abdominal examination, Vandel's ring was felt. The upper segment was very tight and the lower segment was loose. A Vandel's ring was felt. Then mother was dehydrated, membranes were ruptured, and there was hot, dry vagina. Right? Now, what do all these things point towards? All these things point towards obstructed labor. And again, your answer is going to be cesarean section. Are you understanding? So be very, very careful with your questions. जहां पे obstructed labor होगा, cesarean section. जहां पे CPD होगा, cesarean section. Right? If the head of the fetus is more than equal to +2, and the cervix is fully dilated, there is no CPD, and head of the baby is completely rotated, then you can apply forceps. A very important thing which you should also remember, if your question is talking about fetal distress, जो कि यहाँ पे नहीं है. In this question, they are not saying fetal distress. Their heart rate is 140 beats per minute. If your question is talking about fetal distress, please remember, in fetal distress, we do not apply vacuum. We do not prefer vacuum in case of fetal distress. We do not prefer vacuum in case of preterm deliveries. In preterm deliveries also, we do not prefer vacuum. Clear to all of you? Yes? If cervix is fully dilated, then how it is called arrest? So this is arrest of second stage. There are two kinds of arrest. Arrest of active phase and arrest of second stage. Arrest of active phase का मतलब है कि cervix is not fully dilated. Right? Arrest of second stage का मतलब है कि cervix is fully dilated and अब delivery नहीं हो रही है. That is arrest of second stage. Clear? Okay. Then, coming to the next question, which was a very easy one. A primigravida presents to the emergency room in early stages of labor with adequate uterine contractions. On per-vaginal examination, a gynecoid pelvis is felt, membranes are ruptured, and vertex is in ROP position. How will you manage this condition? Please remember, whenever your patient is in occipito-posterior position, the management is wait and watch. Most of the times, the head of the baby, so occipito-posterior, ROP position, most of the times the head of the baby is going to rotate automatically by 3/8 of a circle. It will become occipito-anterior and vaginal delivery will happen. Right? So you just have to be patient because it is going to take some more time. So you have to just wait and watch, and you are going to go for a normal vaginal delivery. Only if your question says it is deep transverse arrest which has happened, then your answer is going to be cesarean section. Clear to all of you? Tell me, which is the most common pelvis which is associated with occipito-posterior position? Most common pelvis associated with occipito-posterior position, number 1. Number 2 question is persistent occipito-posterior position seen in. Number 3 question, direct occipito-posterior position seen in. Tell me. So most common pelvis associated with occipito-posterior is android pelvis, direct occipito-posterior and persistent occipito-posterior position seen in anthropoid pelvis. Right? Deep transverse arrest is most common in which pelvis? Android pelvis. Okay. So all of you are very good in your OBGY. I can see that. Good. Another question which came in NEET 2021 related was this question. Very conceptual, very nice question. A 26-year-old pregnant woman on examination was found to have infraumbilical flattening and fetal heart sounds were heard over the lateral side. What could be the fetal presentation or position? Right? So you have to tell. There is infraumbilical flattening and fetal heart sounds are heard on lateral side. Now, whenever you get these two terms, it means it is occipito-posterior position. Right? So see over here. This is an image. Image A is showing you occipito-posterior and image B is showing you occipito-anterior. See over here. When there is occipito-posterior position, can you see over here? Just below the umbilicus, there is a flattening, whereas in occipito-anterior, this over here is occiput, so this is occipito-anterior. There is no flattening, number one. Number two, always you can hear fetal heart sounds best through the back of the baby. So because over here the back of the baby is towards the flank, that is why fetal heart sounds will be heard over the flank. Whereas in case of occipito-anterior position, fetal heart sounds will be very easily heard because back is towards the umbilicus, right? So in case of occipito-posterior position, abdomen below the umbilicus looks flat, number one. Number two, fetal limbs are present near the umbilicus. Fetal back is towards the flank and that is why fetal heart sounds are heard more towards the flank. Clear to all of you? Yes. So over here this is infraumbilical flattening and fetal heart sounds are heard over the lateral side. So the answer to this question will be occipito-posterior position. This is again all this I have shared with you in the group. Now identify the blue colored area shown in the image below. So over here what you are seeing an area which is starting between junction of S2, S3 and it is ending between junction of S4, S5. Right? So over here just look. I have made this table for you. Quickly let us revise. What is the inlet? What are the boundaries of the inlet? The boundary of the inlet is anteriorly you have the pubic symphysis, posteriorly you have the sacral promontory and laterally you have iliopectineal line. So this means कि अगर हमें ऐसे दिखाना होगा, so I have pubic symphysis anteriorly and I have sacral promontory. So this area, if they would have asked you, this area would have been the inlet. Right? Because inlet is bounded anteriorly by pubic symphysis and posteriorly by sacral promontory. So this is inlet. Then comes cavity. Ab cavity mein there are two types of planes. One is the plane of greatest pelvic dimension and one is the plane of least pelvic dimension. Plane of greatest pelvic dimensions ki anteriorly you have pubic symphysis, posteriorly you have junction of S2, S3. Right? And laterally you have the obturator foramen. So this means this line which they have shown you over here, which is anteriorly pubic symphysis, posteriorly junction of S2, S3. This is S2, this is S3. This is the plane of greatest pelvic dimensions. Then you have a plane of least pelvic dimensions which anteriorly is bounded by pubic symphysis. Posteriorly you have junction of S4, S5. So this over here is plane of least pelvic dimensions. So anteriorly you have pubic symphysis, posteriorly you have junction of S4, S5. Now mid pelvis is that area of the cavity which lies in between the plane of greatest pelvic dimensions and least pelvic dimensions. So this area, blue colored area which they have marked, this is actually mid pelvis which is lying in between the plane of greatest pelvic dimensions and the plane of least pelvic dimensions. Then you have something which is called as anatomical outlet. Anatomical outlet anteriorly is bounded by pubic symphysis, posteriorly it is bounded by tip of coccyx. So this over here is anatomical outlet, right? Now this area which I'm going to mark yellow color area, which is between plane of least pelvic dimensions. So this was the plane of least pelvic dimensions. This was the plane of least pelvic dimensions. So this yellow area which is lying in between the plane of least pelvic dimension and the anatomical outlet is obstetrical outlet. Are you understanding this? So this is obstetrical outlet. Clear? So do you know now, do you understand if they mark different areas how you are going to recognize? Okay. Next question. While conducting a delivery, you perform the maneuver shown below. So what are you doing? You are doing controlled cord traction. With one hand, you are pushing the placenta up, and with the other hand, you are giving traction to the cord. So this maneuver is controlled cord traction. Now, following this, there is incomplete separation of placenta and massive hemorrhage. So, patient को बहुत bleeding हो रही है and the placenta did not come out. There is incomplete separation of the placenta. So, common sense tells me that if the placenta did not come out, right, and there is excessive bleeding, what am I going to do? Quickly, I'm going to take my hand inside, I'm going to make the uterus relax, I'm going to make the patient relax, and I'm going to remove the placenta and then give her oxytocin. So over there, here they have written start oxytocin and wait for spontaneous delivery. No, right? Because patient is having excessive bleeding, I'm not going to start oxytocin and wait for spontaneous delivery. Uterine massage, no, uterine massage at this point just now is not going to help. I'm going to remove the placenta and then I'm going to do uterine massage. Arrange for blood and use Crede's method. Crede's method is no longer done. I'm going to go for manual removal of placenta. Clear to all of you? Okay. In operative obs, the question which they had asked you, a pregnant woman with history of classical cesarean section because of fetal growth retardation in previous pregnancy presents to you. She is at 35 weeks of gestation with breech. What is the next step in management? Now, are you going to do a cesarean section at 37 weeks, advise ultrasound and visit after 2 weeks, internal podalic version or external cephalic version? Please understand, if your patient has undergone classical cesarean section, as I told you, is what? Is a cesarean section which is done in upper uterine segment. So if it is a case of classical cesarean section, you are not going to do any version. No versions are you going to do. You have to do a repeat cesarean section at 37 weeks. Version, external cephalic version, is absolutely contraindicated in classical cesarean section patients. Whenever there is a case of classical cesarean section, next time when the patient conceives, it has to, a cesarean section has to be done. Clear to all of you? Yes. Now, ACOG says that in case of previous lower segment cesarean section, if it is a case of lower segment cesarean section and you have a breech, now the new ACOG recommendation is कि previous LSCS hai and breech hai, then you may attempt a version. But classical cesarean section ke saath you are never going to do a version. Right? The other change which has come in ACOG guidelines is, I told you yesterday, earlier it was said that if it is chronic incision, then you have to do a cesarean section. So 2 lakh or VBAC was contraindicated in chronic incision. Now the new ACOG recommendations are that chronic incision is not an absolute contraindication for 2 lakh. Right? Now, suppose your patient has previous cesarean section and this time she has twins. Can you attempt vaginal delivery? Yes. So, in case of twins with previous history of lower segment cesarean section, you can go for 2 lakh TOLAC, that is trial of labor after cesarean. What are the conditions which are absolutely contraindicated, where you are not going to attempt vaginal delivery after cesarean section? If it is, classical cesarean section, or a T-shaped cesarean section, or if there is previous history of uterine rupture, or if in present pregnancy there is macrosomia or malpresentation, then that is a relative contraindication. Clear? Indication of ECV, very easy. Whenever there is a single baby and the single baby is either in breech or in transverse lie, then you go for ECV. Time for doing ECV is 36 weeks. Right? Next question, which was related to obstetrical score. The question is, a 28-year-old pregnant woman came for routine clinical checkup in her second trimester. She has history of delivering 2 healthy full-term twins 4 years back. What would be her obstetrical score? CPD है, imagine, previous cesarean section है, and this time there is CPD. What are you going to do? Definitely you are going to go for a cesarean section. Right? So that's an absolute indication. So tell me, so this patient, what is a gravida? Gravida is the number of time a female conceives. Right? So this is her second pregnancy. First time when she had conceived, she had got twins. And now she has conceived again. So she is G2. Right? And parity is number of previous pregnancies. Parity may you never count present pregnancy. Number of previous pregnancies which had gone beyond the period of viability. Now, because she has given birth to twins, but twins are a result of single conception. So twins will be taken as single parity. So she is G2P1, right? Are you understanding? So many times you get confused if question would have been like this. A 28-year-old pregnant woman at 34 weeks gestation came for routine checkup. Now what you tend to do is, because इन्होंने कहा 34 weeks gestation, so you start counting present pregnancy also in parity. You are never going to count present pregnancy in parity, right? Parity is number of previous pregnancies which had gone beyond the period of viability, and the period of viability in India is 28 weeks. Clear to all of you? So whether it is twins or whether it is triplets, they are always counted as one because they are product of the same time of conception. Right? Conception, female had conceived once and she had given birth to 2 children. That's a different thing. Okay? Now, where to count stillbirth? You tell me. If your question says stillbirth happened at 32 weeks, right? Or stillbirth happened at 36 weeks, you are going to count it in viable pregnancies. If they say that the death of the fetus happened at 24 weeks, you are going to count it in pre-viable, right? Then, a 30-year-old woman on OCPs for the past 6 months. Where to count abortion? Abortion is not counted in parity. Abortion का मतलब ही होता है that the pregnancy has ended at less than 20 weeks. So you are never going to count abortion in parity. Now, suppose I say in this question, if I say she has history of full-term twins 4 years back and she has history of abortion. Right? Now what will her gravida and parity be? Now her gravida and parity will be G3P1. Still it will be P1, but now her gravida will change to 3 because she had conceived. This is the third time she has conceived. First time when she conceived, she had abortion. Second time when she conceived, she had twins. And third is her ongoing pregnancy. Right? So it will become G3P1. Now sometimes in your questions you will see G3P1 plus 1 written. Now whenever there are two numbers written in front of parity, A plus B, then the second number which is written over here, it represents abortion. Right? Okay. Now comes a 30-year-old woman on OCPs for past 6 months presents with amenorrhea for past 6 weeks. What would be the best method of assessing gestational age? See, best method of assessing gestational age is always clinically by using Naegeli's formula. But then in 4 conditions, you do not use Naegeli's formula. In these 4 conditions, you rely on ultrasound. What are those 4 conditions? If cycles of the female before she had conceived, if they were irregular, if a female was on OCPs and while she was on OCPs she has conceived, if she was breastfeeding and she has conceived while she is on breastfeeding, or if female doesn't remember her LMP. In these 4 conditions, Naegeli's formula is not a reliable method to calculate EDD. In these 4 conditions, you are going to use ultrasound, and the best parameter on ultrasound to know the gestational age is crown rump length. So in this case, the answer is crown rump length by ultrasound. That is option A. Then comes next question. A 27-year-old mother with 7 weeks pregnancy at antenatal care OPD has history of accidental exposure to radiation. What will you advise her regarding pregnancy management? Now, please remember that up till 5 rads of radiation exposure is safe during pregnancy, right? Now, suppose there is a history of accidental exposure, accidental X-ray being done. So, if normally X-rays are contraindicated in pregnancy, but just in case for diagnostic purpose, हमें X-ray करना पड़ता है, right? Then in that case, the pregnancy should not be terminated. You have to continue the pregnancy. It will not have any harm on the fetus. Right? The other thing which you have to remember is that in pre-embryonic period is up till 2 weeks after fertilization. Fetus is following the productive conception follows all or none law. What do you mean by that? So if there is any teratogenic exposure, so up till 2 weeks of fertilization, अगर product of conception पे कोई भी teratogenic exposure होगा, that teratogenic exposure could be, in the form of radiation, it could be in the form of drugs, it could be in the form of heat, then it follows all or none law. What does that mean? Either the fetus is going to completely escape the injury, right? And there won't be any effect on the fetus, or the fetus is going to abort, right? Now, the most teratogenic period is embryonic period, and this is a question from where to when is embryonic period? It is from 3 weeks to 8 weeks after fertilization. It is not pregnancy, it is 3 to 8 weeks after fertilization. 3 to 8 weeks after fertilization का मतलब होता है 5th to 10th week of pregnancy. So 3 to 8 weeks after fertilization or 5th to 10th week of pregnancy is the most teratogenic period, which is embryonic period, right? So I will advise her to continue pregnancy. There was an accidental exposure, that is okay. So I will tell her no problems, continue with your pregnancy, right? Okay. Then this was a question which came in NEET 2022, and again it created a lot of controversies. A primigravida woman at 12 weeks of gestation comes to antenatal clinic for nutritional advice. Which of the following would you recommend? Now, till now our national guidelines said that throughout pregnancy you have to give 350 kilocalories additional, right? Throughout pregnancy, additional 350 kilocalories have to be given in pregnancy. Now, how did our national guidelines come to this? They came to this conclusion. They assumed that the weight gain during pregnancy is 12 kgs And they then bifurcated this into three parts, that in first trimester additional 85 calories are needed, in second trimester 280 calories, and in third trimester 470 calories are needed. And so they said ki overall let us keep it an average of 350 kilocalories in all trimesters throughout pregnancy. So whatever your park has said is 350 kilocalories, additional 350 kilocalories that has come from this. From our national guidelines, that in first trimester 85, in second trimester 280, and in third trimester 470 kilocalories. Right? Now, according to international guidelines, in first trimester no additional kilocalories are needed. In second trimester 350, and in third trimester 450 kilocalories are needed. Right? So now, with keeping this in mind, keeping our national guideline in mind, answer this question. Additional 300 kilocalories in second trimester. So what did they say? They say overall 350 chahiye. First trimester mein our national guideline is saying 85. Second trimester mein 280. So yes, 280 is roughly 300. Then the additional 300 kilocalories in first trimester, no. Our national guidelines say 85. Right? Additional 400 kilocalories in third trimester, no. Our national guidelines say 470 kilocalories, which is roughly 500. 300 kilocalories throughout pregnancy, no. It says 350 kilocalories throughout pregnancy. So the best answer to mark over here will be option A. Clear to all of you? Yes. Infections in pregnancy. Now, a question came in NEET 2021, and that was: a primary at term presents with labor pain and multiple painful vesicles on the vulva. No rashes were found on other parts of her body. What will be your management? So first tell me, what infection are you thinking mother is having? She is having genital herpes infection. Now, whenever a mother is going to have genital herpes infection, definitely I am going to give her acyclovir. That's fine, that I have to give her acyclovir. But whether am I going to go for cesarean section or whether I am going to go for vaginal delivery? Now, whenever there is genital herpes infection, you have to do a cesarean section if it is active genital herpes infection, or if prodromal symptoms like vulval pain are present, then also you have to go for cesarean section. So in this case, I am going to go for acyclovir and elective cesarean section. Right? Now, whenever you are doing, vaginal delivery in genital herpes infection, so if it is not an active infection and you are doing vaginal delivery, then remember, in genital herpes infection, ARM should be avoided, instrumental delivery should be avoided, and fetal scalp monitoring should be avoided. Right? Drugs in pregnancy. I hope you understood this question, all of you. Acyclovir and elective cesarean section. Drugs in pregnancy. The question which came on drugs in pregnancy was related to anticoagulants in pregnancy, and the question was: a pregnant woman at 36 weeks of gestation who has prosthetic valve replacement for mitral stenosis is on warfarin. Her INR is 3. What is the appropriate next step of management in this case? Right? So at 36 weeks on warfarin, what am I going to do? At 36 weeks, whenever your patient is on anticoagulant and that anticoagulant is warfarin, because warfarin is a very strong anticoagulant, number one. Number two, because warfarin can cross the placenta and it can go into the fetus, that is why at 36 weeks of pregnancy, we replace warfarin and we start low molecular weight heparin. Right? So it is, you are going to stop warfarin and start low molecular weight heparin. Clear to all of you? Yes? Okay. Now, anticoagulants in pregnancy. Now, anticoagulants in pregnancy ke baare mein, just now on my Instagram handle, around 4-5 days back, I had posted everything related to anticoagulants in pregnancy there. So there is a small video of 1 or 2 minutes. No, that is a little long. I think it's a 5 minutes video where I have explained you every detail of anticoagulants in pregnancy. So please go and watch that reel which is there on my Instagram handle, and you will get all information related to anticoagulants in pregnancy there. I am not repeating it here. Then a pregnant woman was prescribed endomethacin. Which of the following effects does the drug have on the fetus? So please remember, endomethacin you use in pediatrics. And why do you use in pediatrics? You use it for closure of ductus arteriosus, right? So if there is a patent ductus arteriosus, for its closure you are going to use endomethacin. So if I am using endomethacin, now Abhinav is asking a very good question. When to give heparin and when to give low molecular weight heparin? See, throughout pregnancy, we prefer low molecular weight heparin. It is only just before delivery and in the postpartum period that I'm going to prefer unfractionated heparin. Why? See, unfractionated heparin, it has some advantages and some disadvantages with respect to low molecular weight heparin. तो unfractionated heparin का disadvantage क्या है? अगर आपने unfractionated heparin को बहुत लंबा यूज किया, it can lead to thrombocytopenia and it can lead to decrease in bone mineral density, right? So, and number 3, its effect is very erratic, right? So its response is unpredictable. So that is why we prefer low molecular weight heparin to unfractionated heparin throughout pregnancy. Then why is it that just before delivery and just after delivery, why we prefer unfractionated heparin? This is because unfractionated heparin, its action is very short-lived. So its response can be very quickly withdrawn, right? So that is why just before delivery and immediately after delivery, we prefer unfractionated heparin in comparison to low molecular weight heparin. Now, ma'am, the answer should be aspirin and heparin. See, bacha, agar answer was to be aspirin and heparin, I agree with you कि as per the recent guidelines, whenever it is a bioprosthetic valve replacement, or whether it is bioprosthetic valve replacement or whether it is mechanical valve replacement, in both these conditions we give aspirin. Bioprosthetic में only aspirin, mechanical valve में aspirin and anticoagulant, right? Now in this question, why am I not choosing aspirin over here is क्योंकि इस patient को शुरू से aspirin देना था. In pregnancy, starting from the beginning, I should have given her aspirin and anticoagulant. At 36 weeks of pregnancy, achanak se I am not going to introduce aspirin. Are you understanding? Is this clear to you? In this patient, in all patients who have valve replacement, from day 1 of pregnancy, you have to give them aspirin. In mechanical valve, you have to give anticoagulant and aspirin. In bioprosthetic valve, you have to give only aspirin, right? अब यहाँ पे they are saying कि अभी तक till 36 weeks I was giving her only warfarin, and now all of a sudden at 36 weeks I am putting her on heparin and aspirin. No. Okay. Now because endomethacin can lead to premature closure of ductus arteriosus, that is why endomethacin is never given beyond 32 weeks of pregnancy, right? Now ACOG says that up till 32 weeks the best tocolytic is endomethacin. इंडिया में हम क्या यूज करते हैं? In India, the tocolytic which we are using and which is the best is nifedipine. But according to ACOG, up till 32 weeks, best is endomethacin. And because endomethacin cannot be used after 32 weeks, so between 32 weeks to 32 to 34 weeks, best is nifedipine. Remember, tocolytics should never be used after 34 weeks. You are never going to use tocolytics after 34 weeks. So no tocolytic to be used after 34 weeks. Endomethacin has two drawbacks. Number one, it can lead to premature closure of ductus arteriosus. That is why it is never used after 32 weeks. And endomethacin can lead to oligohydramnios. That is why it is never used for more than 48 hours. Clear? Next question, very easy question related to men. So these were OBS questions which had come. Now coming to gynae questions which were asked. Now, hormone acting on post-ovulatory endometrium is, all of you know that in the post-ovulatory phase, the hormone which is going to act will be progesterone. In the pre-ovulatory phase, it is estrogen. Which hormone initiates menstrual cycle? It is FSH. Which hormone maintains corpus luteum in a non-pregnant female? It is luteinizing hormone. Hormone which maintains corpus luteum in pregnancy? HCG. Hormone which prevents corpus luteum from undergoing luteolysis. Again HCG. First stimulus for fetal testes to produce testosterone. HCG. Right, so that's the first stimulus for fetal testes to produce testosterone. And same question was asked in 2022. Testosterone helps in development of various organs in the fetus. Which of the following is the first stimulus for its production? So normally in testes, Leydig cells are the one which produce testosterone, and LH acts on Leydig cells to produce testosterone, right? When does testosterone production begin in male testes? It begins at 8 weeks of intrauterine life. When is testosterone maximum in intrauterine life? It is 15 weeks of intrauterine life. But although LH is the hormone needed by the pituitary, which is secreted by the pituitary, and it acts on the Leydig cells to produce testosterone, but the first stimulus is not LH. First stimulus is HCG. It is HCG which is the first stimulus which acts on the testosterone, on the testes to produce testosterone, and that is why we say LH and HCG are functionally the same. Right? Because LH is the hormone which maintains corpus luteum in non-pregnant females. HCG does the same function in pregnant females. LH is the one which acts on Leydig cells to produce testosterone in male testes. HCG is the first stimulus. Right? Then in gynae, they are very fond of asking you questions related to diagnosis, where you have to diagnose the condition based on the clinical case which they have given you. So over here, a 45-year-old woman presented with lower abdominal mass and lower abdominal discomfort. On examination, uterus is uniformly enlarged and adnexa is free. MRI shows presence of myometrial cyst. What is the most probable diagnosis? Please remember, on MRI, if you are getting a myometrial cyst, that means, why is the cyst? Cyst ka matlab hai something fluid is there, right? So what happens in adenomyosis? In adenomyosis, endometrium enters into myometrium. Endometrium has glands. So endometrial glands will now be present in myometrium, and at the time of menstruation, ये जो glands हैं जो कि hormonally active हैं, they are going to produce blood, right? And that is why this blood is going to appear in the form of a cyst. These glands with fluid and blood is going to appear in the form of cyst, right? So myometrial cyst you are going to get in case of adenomyosis. Is that clear to all of you? Another very important thing. In case of endometriosis, the endometrium is present outside the uterus. Because endometrium is present outside the uterus, so uterus will not be enlarged. तो जो ये इन्होंने दिया ना कि uterus is uniformly enlarged and adnexa is free, this is not something which you are going to get in endometriosis. In endometriosis, there are very typical per vaginal findings which you get. In endometriosis, they will say that the uterus is fixed and retroverted. Right? Uterus will not be tender and adnexal mass will be present. What is that adnexal mass? It is chocolate cyst. And adnexal tenderness will be present. Right? So in case of endometriosis, patient आपके पास complaint लेकर आएगा dysmenorrhea की, dyspareunia की. Very important thing. अगर question में dyspareunia दिया है, so that means it is pointing towards endometriosis. Dyspareunia is never seen in fibroid. It is not seen in adenomyosis. It is not seen in polyp. Right? Then in case of endometriosis, patient can come to you with infertility or adnexal mass. Out of these four, any three, the question is going to say that patient is coming to you with any three. Right? Then in endometriosis, per abdomen findings will be nothing. Uterus will never be enlarged, so no per abdominal finding. Per vaginally, you are going to get a fixed retroverted uterus. Uterus tender nahi hoga, but adnexa mein you are going to feel a mass and adnexal tenderness will be present. The investigation of choice for endometriosis is laparoscopy, but the first investigation which you do in endometriosis is TVS or ultrasound, right? Now, why is it not a case of fibroid? Now, in case of fibroid, again, patient can come to you with lower abdominal mass and discomfort, but uterus will not be uniformly enlarged. Uterus is irregularly enlarged. Why irregularly enlarged? Because fibroid will be on one side of the uterus, right? So, uterus is going to be irregularly enlarged, and MRI mein there won't be any myometrial cyst, right? So, it cannot be fibroid. In case of fibroid, patient comes to you most commonly with complaint of menorrhagia, and yes, they can be plus minus dysmenorrhea. Right? Dysmenorrhea is never the main complaint. Most common complaint is menorrhagia. You on per abdomen, uterus will be enlarged, but it will be irregularly enlarged. Similarly, on per vaginal examination, it will be enlarged, but it will be irregularly enlarged and uterus will not be tender. In case of adenomyosis, the most common complaint with which a patient comes to you is menorrhagia and dysmenorrhea. You do not get any per abdominal findings. Per vaginally, uterus is uniformly enlarged and globular. It is 10 to 12 weeks pregnant size uterus. It is never more than 12 weeks pregnant size uterus. In case of adenomyosis, uterus uniformly enlarged होगा, uterus में tenderness present होगी, that is called as Halban sign. लेकिन adnexa free होगा and adnexa में there won't be any tenderness, right? In case of endometriosis, because of chocolate cyst, adnexa में mass feel होगा and adnexa में tenderness present होगी. But in case of adenomyosis, adnexa will be free. Right? Adnexa is the test tubes and the ovaries. So, adnexa will be free. Adnexa mein no mass will be felt. Right? And the investigation of choice for adenomyosis is MRI. Now, instead of saying that you are getting a myometrial cyst, they could have also said that junctional zone is more than equal to 12 millimeters. So, that is a finding which you get on MRI in case of adenomyosis. On ultrasound in adenomyosis, you can get a Venetian blind appearance. A Venetian blind appearance. Right? Now, when we are talking about polyp में patient complaint लेकर आती है irregular bleeding की. In fibroid, patient comes to you with excessive bleeding, but it will not be irregular. Irregular bleeding, intermenstrual bleeding, अगर ऐसी terminologies मिल रही हैं, it means the question is about a polyp. In a polyp होता क्या है? It's a small mucosal growth which is happening. So obviously on per abdomen, no findings. On per vagina, no findings. Uterus will not be enlarged, nothing. Right? And the investigation of choice is ultrasound. Ultrasound में it becomes difficult to differentiate between fibroid and polyp sometimes. So in that case, you are going to switch on the Doppler, and in case of polyp, you get a typical finding, and that is when you switch on the Doppler. Just now I'll show you the image. You will see a blood vessel coming up till the center of the polyp, which is called as feeder vessel sign. Whereas in case of fibroid, a fibroid is surrounded by a pseudocapsule, and all the blood vessels which supply the fibroid, they are present in this pseudocapsule, right? Whereas in case of polyp, there is a single blood vessel which is coming up till the center. Clear? So that is how you differentiate between these conditions: polyp, fibroid, endometriosis and adenomyosis. Then comes the next question. A pregnant female, this was asked in NEET PG 2019. A pregnant woman with fibroid develops severe acute pain at 28 weeks of gestation. So the moment we listen to this, the moment we read this, कि fibroid है, pregnancy है, 28 weeks है, then we think about red degeneration of fibroid. But go ahead and see what the question is saying. That is why it is very important for you to read the entire question properly before you mark the answer. There is no history of fever. So in case of red degeneration of fibroid, you get history of fever. And in case of red degeneration of fibroid, you get leukocytosis. WBC count is raised. यहाँ पे क्या लिखा है? There is no history of fever. And WBC count is normal. This means it is torsion of fibroid. Right? Red degeneration में there will be fever. Red degeneration में ESR will be high. Red degeneration में WBC count will be raised. Right? Now, whenever there is red degeneration, always you have to go for conservative management. Conservative management may, because it is an aseptic condition, in conservative management, do not give antibiotics. Just put the patient on bed rest, give her analgesics and give her antiemetics. Right? No myomectomy has to be done. No termination of pregnancy has to be done for red degeneration of fibroid. Clear? Next question. A 30-year-old married female came for infertility evaluation. How to exclude preterm labor? Okay. So tell me, preterm labor में, is the patient going to say severe acute pain in abdomen? Is the patient going to give you this history? Patient is going to say that the pain is coming and going. Pain will be coming on and off, right, because of contractions. Severe acute pain in abdomen nahi hoga in preterm labor, right? Okay. Then coming to this question over here, a 30-year-old female coming to you for infertility evaluation. There are two intramural fibroids which are found at both right and left cornua of the uterus. Husband's semen analysis is normal. What is the appropriate management? Right? Now tell me, how are you going to manage? See, normally what we do is, normally intramural fibroids, they do not lead to infertility. It is mostly the submucous fibroids which lead to infertility, right? But here the question is telling you that there are intramural fibroids which are present near the cornual end, And probably this is the reason why they are leading to infertility, whereas husband's semen analysis report is normal. So now when I have excluded all other causes of infertility and I am seeing that there are fibroids present, I will presume that it is these fibroids which are leading to infertility. So definitely my option will be to remove the fibroids. Removing the fibroids is called as myomectomy. And which type of myomectomy am I going to do? I'm going to go for a laparoscopic myomectomy. If it would have been a type 0 or a type 1 submucous fibroid, then I would have gone for hysteroscopic myomectomy. In case of intramural fibroids, or in case of subserosal fibroids, or in case of type 2 submucous fibroids, you have to go for laparoscopic myomectomy. So over here there is no option like laparoscopic, so I'm going to mark the answer as myomectomy, simply myomectomy, right? Now, question on Rh negative pregnancy. In current obstetrical advanced era, best test for monitoring a sensitized Rh negative mother. Now, first tell me, what is a sensitized Rh negative mother? Sensitized Rh negative mother means indirect comb test is positive. Now, whenever an Rh negative pregnant female comes to you, the first thing which you have to do is you have to check whether her husband is Rh negative or positive. Because if her husband is also Rh negative, then this female is not a high risk female. I'm going to manage her like any other normal female who is pregnant, right? Now, if husband is Rh positive, then what we do is at the first antenatal visit, we do an indirect comb test and we repeat this indirect comb test at 28 weeks, between 24 to 28 weeks, ideally at 28 weeks. Now, when I repeat the indirect comb test at 28 weeks, and if I see that indirect comb test remains negative, right? So then at that point of time at 28 weeks to this female, I'm going to give her anti-D. How much anti-D? 300 micrograms of anti-D or 1500 international units of anti-D. But if at 28 weeks I see that the indirect comb test is positive, this means that now fetal blood has entered into mother's blood. It has stimulated mother's immune system and now mother's immune system has produced antibodies against fetal Rh antigen. Right? Now I want to know how many antibodies has the mother produced. For that I am going to do antibody titer. Now, antibody titer, if it is 1:16, 1:16 is called as critical titer. So, 1:16 is what is called as critical titer. Now, if titer is less than 1:16, अब यहाँ पे maths नहीं apply करनी है. In this case, less than 1:16 means 1:2, 1:4, 1:8, right? So if titer is less than 1:16, that means although antibodies are produced, but they will not lead to a lot of hemolysis in the fetus. They will cross the antibody, they will cross the placenta and lead to hemolysis in the fetus, but that hemolysis is not going to be very significant, right? So in that case, I am going to repeat the titer after every 4 weeks. I am going to do fetal monitoring starting from 32 weeks and I am going to deliver this patient between 37 to 38 weeks, right? Now, if antibody titer is equal to critical titer or more than critical titer, that is 1:16, 1:32 or 1:64, any of this, right? In that case, my next step is to see how much hemolysis has happened. And in order to know how much hemolysis has happened, I am going to do peak systolic velocity of middle cerebral artery. जब भी हमें fetal anemia को detect करना है, we go for peak systolic velocity of middle cerebral artery. If peak systolic velocity is less than 1.5, that means बहुत ज़्यादा fetal anemia नहीं है. In that case, keep on repeating peak systolic velocity after every 1 to 2 weeks. Do fetal monitoring at 32 weeks and deliver the baby between 37 to 38 weeks. Right? But if peak systolic velocity is more than equal to 1.5 mom, in that case, I need to know what exactly is the hemoglobin or hematocrit of the baby. So in that case, my next step becomes cordocentesis. So if hematocrit of the baby, I'm going to take cord blood and I'm going to check the hematocrit of the fetus. If hematocrit is more than equal to 30%, I will again keep on repeating this hemoglobin and hematocrit weekly, and I will do all that step which I did over here. I will do fetal monitoring at 32 weeks and starting from 32 weeks, and I will deliver between 37 to 38 weeks. But if hematocrit is less than 30%, in that case, I should look at the gestational age. If gestational age is more than 35 weeks, deliver the baby. If gestational age is less than 35 weeks, then go for intrauterine transfusion. Clear? Now, as far as Doppler is concerned, remember, in case of Rh negative pregnancy or whenever you want to check fetal anemia, right? For example, in case of twin to twin transfusion syndrome, the Doppler which you do is middle cerebral artery Doppler, and you check the peak systolic velocity. To predict PIH, the Doppler which you do is uterine artery Doppler, as I told you yesterday. And for prognosis of PIH and IUGR, the Doppler which you do is umbilical artery Doppler. Clear? So in this question, they are saying that indirect Coombs test is positive. So if indirect Coombs test is positive, what should I do? I should go for middle cerebral artery Doppler waveform. Clear to all of you? In India, the most common, see, if question comes most common cause of PMB in India, specifically in India, then yes, cancer cervix. But if question comes most common cause of PMB, then that is atrophic endometrium or senile endometritis. Whenever we are telling you a time to deliver, कि हमें डिलीवरी करनी है 37 वीक्स पे, हमें डिलीवरी करनी है 38 वीक्स पे, it means induction of labor. Otherwise, how is the fetus going to know कि I want to deliver the baby at 37 weeks? Uterus कैसे contract करेगा? Right? I don't have some Harry Potter wand or something that I'm going to say, okay, now you contract, and the uterus will start contracting. Whenever we say a delivery has to be done, it has to be induction of labor. Then, what will be the level of anti-Mullerian hormone in low ovarian reserve? Now, remember, the best test for low ovarian reserve, ovarian reserve is anti-Mullerian hormone. Who is producing anti-Mullerian hormone? Anti-Mullerian hormone is produced by the small growing follicles, the preantral and the antral follicles, right? Normally, the anti-Mullerian hormone levels are 1 to 3.5. If it is less than 1, that's borderline. If it is less than 0.5, that is decreased reserve. So you simply have to remember less than 1 means that the problem is there. So over here, less than 1, right? Now, most commonly used test for ovarian reserve is serum FSH levels, which has to be done. All these tests have to be done on day 3 of the cycle, whereas anti-Mullerian hormone can be done on any day of the cycle. That is why it's the best test. But other tests are FSH levels. So FSH levels will be increased in case of decreased ovarian reserve. Then antral follicle count, you count the number of follicles in the ovaries. Again, antral follicle count will be less if there is decreased ovarian reserve. and serum inhibin B levels will be less. All of you know that inhibin B is produced by the granulosa cells of the follicles. So अगर follicles कम है तो inhibin B कम होगा, and because inhibin कम होगा, the negative feedback on FSH will be gone, so the levels of FSH will increase. So increasing FSH, decreasing inhibin and decreased antral follicle count, they are all signs of decreased ovarian reserve. Now, do you test for decreased ovarian reserve in all females who come to you with infertility? No. In all females who come to you with infertility, in all couples who come to you for infertility, there are 3 basic investigations which you do in all of them. What are those? Number 1, you do test for ovulation. And generally the test which you do for ovulation is serum progesterone levels, right? Then number 2, you do HSG, and number 3, semen analysis. These are the tests which you do in all females or all couples who come to you with infertility. So in which couple am I going to do the test for decreased ovarian reserve? I am going to do test for decreased ovarian reserve if female's age is more than equal to 35 years, if she is a chronic smoker, if she has some history of radiotherapy or chemotherapy or any history of surgery, or if her mother has history of premature menopause, right? So in these conditions, I suspect decreased ovarian reserve and I go for anti-Mullerian hormone testing. Now, there were certain image-based questions which have come. So this question we've already discussed, where you had to tell the grade of placenta previa, and I told you this is type 3 placenta previa. Then there was this question which had come, and from the image you can see what you are seeing over here. This is an ultrasound image, and in this ultrasound what you are seeing? You are seeing that this over here is a mass in the uterus, and this is a vessel. The Doppler has been switched on. There is a vessel which is coming up till the center, a single vessel coming up till the center. This means this is endometrial polyp. This is what is called as feeder vessel sign. Very, very important image. This is a feeder vessel sign and this is an endometrial polyp. Then identify the type of hymen shown in the image. NEET 2022 question. So over here what you are seeing that this is the hymen. This is one side, this is other side, and over here you can see a septa. So this over here is a septate hymen, right? So this is a septate hymen. These are all types of hymen which are shown to you. Please check over here. Cribiform hymen. Cribiform hymen means sieve-like hymen. This is imperforate hymen, annular hymen, septate hymen, right? Then the instrument shown is, now what is this instrument shown? This instrument is it is a Fallop ring applicator. You apply Fallop ring over here, and with this you are going to go for laparoscopic sterilization, right? So you go for laparoscopic sterilization, right? Who had answered C over here? It is not a submucous fibroid, beta. Do you see a vessel going up till the center? So just now I told you if a vessel goes up till the center, that is a polyp. It is not a fibroid. Fibroid mein you are going to get peripheral blood vessels. Okay. So this instrument was for laparoscopic sterilization, right? Some important points on laparoscopy, I have written them for you. This PDF will be available to you. It is available to you. So this you can go through some important points on laparoscopic sterilization. The most important thing which you have to remember is laparoscopic sterilization is never done in postpartum period. It is always done 6 weeks after delivery. So it is a method of interval sterilization, right? You never do it in the postpartum period, right? Then comes the next question. Over here you have to identify this uterine anomaly. So this is an HSG picture. A 20-year-old woman is evaluated for primary infertility. HSG was done and the following finding was revealed. What is the anomaly seen in the image? Tell me. What is the anomaly seen in the image? Most of you are answering it correctly. So understand, Mullerian malformations, most of the times, Mullerian malformations will be diagnosed incidentally. If patient is coming to you with recurrent abortions and you are getting ultrasound done, then it will be diagnosed incidentally. Or if patient is coming to you with infertility and you've got an HSG done, then it will be diagnosed incidentally. Right? The investigation of choice for Mullerian malformations is 3D ultrasound. Gold standard is MRI, and the last resort for diagnosing this condition is laparoscopy and hysteroscopy. HSG is not the investigation of choice because HSG cannot look at the fundus of the uterus. Right, so it cannot differentiate between septate and biconnovate uterus. So HSG is not the investigation of choice, right? But still they are going to give you HSG images and they are going to ask you to identify the Mullerian malformation. You are going to use the following algorithm which I have taught you in Marrow to identify which Mullerian anomaly it is. Whenever you get an HSG, the first thing which you have to see with respect to Mullerian malformations is, can you see two fallopian tubes or one? Because if you are getting one fallopian tube, then that means it is a case of uniconnovate uterus. There is only one condition where you get single fallopian tube, and that is uniconnovate uterus. So in uniconnovate uterus, you will get one fallopian tube and you will get a banana shaped uterus. Right? Now, if you are getting two fallopian tubes, like in this image, I can see one fallopian tube here and I can see second fallopian tube here. Then I have to look at the number of HSG cannulas which you can see in the image. What is the name of HSG cannula? The name of HSG cannula is Leach-Wilkinson cannula. Very important instrument, Leach-Wilkinson cannula. Right? Now, if you are seeing two Leach-Wilkinson cannulas, that means this patient has two vaginas and that is why two cannulas are needed to put the dye. Now, there is only one condition where you are going to get two vaginas and that is didelphic uterus. So, if two cannulas are visible, you are dealing with didelphic uterus. Now, in this image, I am seeing only one cannula. So because it is one cannula, it cannot be didelphic uterus. Because there are two fallopian tubes, it cannot be uniconnovate uterus. Right? Now if it is one cannula, then either it is a case of septate uterus or a biconnovate uterus. How to differentiate between them? In case of septate uterus, the angle between the two uterine horns will be acute and the distance between them will be less than 4 centimeters. In case of biconnovate uterus, the angle between the two horns will be obtuse and the distance between the horns will be more than equal to 4 centimeters. Right? Another thing, please remember, why am I saying that looking at the fundus of the uterus is very important to differentiate between the two? This is because in case of septate uterus, the fundus of the uterus is normal. In case of biconnovate uterus, the fundus of the uterus is separated. It's bifurcated. It's not normal. So you are seeing a dip in the fundus of the uterus, right? So this is the way you differentiate between septate and biconnovate uterus. Over here, HSG says since I cannot see the fundus of the uterus, that is why differentiating between septate and biconnovate is difficult. But I am going to check the angle between the two horns. Angle between the two horns is appearing to be acute and distance is appearing less than 4 centimeters. That is why it is a case of septate uterus and not a biconnovate uterus. Clear? Now look here. Tell me, this was an image which came in NEET 2021. Tell me, What anomaly are you seeing over here? Which anomaly are you seeing here? Apply what I told you just now and tell me which anomaly. Over here, you can see only a single fallopian tube and a banana shaped uterus. Since it is a single fallopian tube and banana shaped uterus, this is an HSG image of uniconvate uterus, right? In uniconvate uterus, please remember, patient is going to complain of unilateral dysmenorrhea. कभी भी कंप्लेन आए यूनिलेटरल डिस्मेनोरिया की या एक्टोपिक प्रेगनेंसी की या एक्टोपिक ओवरी, these three things are associated with uniconvate uterus. Okay. Next question. A 32-year-old woman came for evaluation of infertility and there was a septum in uterine cavity. What would be the appropriate management in this condition? Now, how do you manage a septate uterus? The management of septate uterus is remove the septa hysteroscopically, which is called as hysteroscopic resection of the septa or hysteroscopic septoplasty. Earlier जो हम surgeries करते थे, they were Tompkins metroplasty and John's metroplasty. They are no longer done. Now, for biconnovate uterus, we go for Strassman metroplasty. For diadelphic uterus, you go for unification surgery. Right? What is the indication for doing surgeries? The only indication for doing surgery on a malformed uterus is if it leads to 3 or more than 3 abortions. Right? Then you are going to do surgery for uterine malformations. So it is hysteroscopy and septoplasty. Next question. Again, it's the same question which was repeated in NEET 2020. This was 2021. Same question was repeated in NEET 2020. So again, it was transcervical hysteroscopic resection of the septa. Then in NEET 2021, there was a question. A teenage patient presented with history of dysmenorrhea and chronic pelvic pain. On ultrasound, transverse vaginal septum was present. What is the most common complication which you are going to see in this patient? Please remember, whenever your patient is having, a pubertal female is complaining of dysmenorrhea, right? Most of the times this dysmenorrhea is primary dysmenorrhea. It is not associated with any pelvic pathology, right? But if, there is Mullerian malformation in a pubertal female, then this Mullerian malformation can lead to endometriosis. So if a pubertal female has endometriosis, normally endometriosis is a problem of reproductive age female. So whenever endometriosis is seen in a pubertal female, right, you have to rule out Mullerian malformations. Instead of asking the question like this, they have asked it the other way around. They have said Mullerian malformation is present, dysmenorrhea is present in a pubertal female. What is the complication which you have to rule out? Endometriosis. So always in my lectures, I make you write one line that in all pubertal females, if you are getting, and if in any pubertal female you are getting endometriosis, rule out Mullerian malformations. So this is the other way around. Clear? Okay. Very important thing which I want all of you to note is what are the gynae complications and what are the obstetrical complications which you can get in case of Mullerian malformations. Gynae complication which you can get is infertility. Infertility is most commonly seen with septate uterus. Then a patient with Mullerian malformation can present to you as a case of endometriosis. She can present to you as a case of dysmenorrhea. If it is unilateral dysmenorrhea, then that means it is uniconvate uterus. Or patient, because of outflow tract obstruction, patient may come to you with hematometra. The obstetrical complications which you can get are recurrent pregnancy loss. Most commonly you get recurrent pregnancy loss with septate uterus. Please remember, If they ask you most common uterine anomaly which leads to first trimester recurrent pregnancy loss, and the second question is most common uterine anomaly which leads to second trimester recurrent pregnancy loss. So answer to first question is septate uterus. Answer to second question is cervical incompetence. Clear to all of you? Okay. Then, because of Mullerian malformations, preterm labor can happen, malpresentations can happen, and ectopic pregnancy can happen. Just now I told you ectopic pregnancy is usually seen in a uniconnovate uterus. Why? Because many times in uniconnovate uterus there is a rudimentary horn. Right? Most common complication overall of Mullerian malformations is recurrent pregnancy loss, and that is the only indication for doing surgery on Mullerian malformation. Now, when we are talking about malpresentations, malpresentation transverse lie. Transverse lie is generally seen in septate uterus and biconnovate uterus, whereas breech presentation is seen in uniconnovate uterus and diadelphic uterus. Right? So transverse lie is seen in septate and biconnovate, and breech presentation is seen in uniconnovate and diadelphous. Clear to all of you? So now a question was asked in NEET 2021 again. So NEET 20 and 2021 had a lot of questions related to congenital malformations. The question is, a 27-year-old female was found to have uterine diadelphous. Which of the following is not likely a complication of this uterine anomaly? Tell me. Tell me quickly. Which is not a complication in this condition? Excellent all of you. It is transverse lie. Transverse lie nahi milta diadelphous mein. It is breech which you get in diadelphous. Abortion you are going to get. Endometriosis you are going to get. Preterm labor you are going to get. Transverse lie you are not going to get. So the answer is transverse lie. Identify the image. Now what you are seeing in this image? In this image you are seeing that the tube, the dye is not spilling out. The dye is collected in the tubes and the tubes are swollen. So this is a case of bilateral hydrosalpinx. Now, if they show you this image and they ask you what is the next step, please remember HSG, the investigation of choice for tubal patency, is HSG. But it is not the best investigation. The gold standard investigation for tubal patency is laparoscopic chromoperturbation. Right? So whenever I get an image like this and they ask me what is the next step, my next step will be laparoscopic chromoperturbation. Right? Now, in case of hydrosalpinx, how do I manage? Hydrosalpinx hair, that means tubes are no longer, they cannot be used now. So I have to do an IVF, right? But if I do IVF, this fluid which is present in hydrosalpinx, it is embryotoxic. So when I will do IVF, ये जो fluid है ये आ जाएगा in uterine cavity and it is going to kill the fetus. That is why what I have to do is I have to first remove these tubes followed by IVF. That is, do a bilateral salpingectomy followed by IVF. These days, instead of doing bilateral salpingectomy, some clips are available. So those clips can also be applied at the cornual end and that can be followed by IVF. Clear to all of you? Yes. Now, although this image was not shown, but they may show you in future. So tell me, what is this image showing you? This image is showing that the dye has come up till the cornual end of the uterus and it has not passed any further. So this is a bilateral cornual block. What is the most common cause of bilateral cornual block? It is physiological spasm. But what is the most common pathological cause? That is genital TB. If they show you this image and they ask you what is the next step, it has to be laparoscopic chromoperturbation plus hysteroscopic cannulation, right? Hysteroscopic cannulation. In hysteroscopic cannulation, you pass a guide wire and you try to, whatever is causing the block, you try to remove the block. Most of the times the block will be relieved and the patient can then conceive, right? But if patient is unable to conceive, then the best management of this condition again is IVF. Clear? Then identify the image. I'm sure all of you will be able to identify. This is a female condom. Why it is a female condom? Because I can see two rings over here, right? So in a male condom, there is a single ring. Over here, I am seeing two rings. So this is a female condom. Now, a female condom FC1 is made up of polyurethane, FC2 is made up of nitrile, and that is the one which is most commonly used. Failure rate of female condom is 5 to 20 per 100 women year, whereas for male it is 2 to 12 per 100 women years. Please remember, female condom is not included in National Family Planning Program, whereas male condom is included in the National Family Planning Program by the name of Nirodh. Now, female condom is distributed free of cost to female sex workers by NACO. Male condom can be used only once, but a female condom may be used twice. Although we suggest them to use it only once, but it can be used twice. Remember, there are two other barrier contraceptives. One is diaphragm and the other is Touré sponge. Diaphragm can be washed and reused up till 1 year. Whereas Touré sponge, once it is inserted in female's vagina, it can be kept maximum for 24 hours, and in those 24 hours, a female can have intercourse any number of times, right? So it can be used multiple times up till 24 hours. An absolute contraindication of female condom is rectocele and cystocele, and female condom, like a male condom, is going to protect against STDs, against PID, and that is why it will protect against ectopic pregnancy. It also protects against HIV, but protection against HIV is better by a male condom than a female condom. It protects against HPV infections and cancer cervix. No barrier method can be used as emergency contraceptive. Clear? Now, next question. In this question, they had shown you an ultrasound and they had said that a 26-year-old married female who had a married life of 2 years visits infertility clinic. She puts her on HMG. On treatment, she developed dyspnea, abdominal pain, and her ultrasound showed the following image. What is the condition called as? Now, what you are seeing over here you are seeing multiple follicles, and these follicles are huge follicles. So multiple huge follicles means it is ovarian hyperstimulation syndrome because patient was using HMG. In case of PCOS, why it is not PCOS? See, in PCOS, अब तक का जो ultrasound criteria था, that was 12 or more than 12 follicles, 2 to 9 millimeters in size. Now the new criteria is more than equal to 20 follicles, 2 to 9 millimeters in size. And these follicles are appearing more than 2 to 9 millimeters. Number one. Number two, they have specifically told you that patient has used HMG. Ovarian hyperstimulation syndrome is most commonly seen with HMG, followed by clomiphene citrate. It is never seen with letronidazole, right? The triggering factor for OHSS is injection HCG. When you give injection HCG, then it triggers this condition. Another thing which they are saying is patient is having dyspnea and abdominal pain. Again, that is a symptom which is seen in OHSS, right? Glint Medico, yes, in case of PCOS, necklace pattern is seen, but then that is not a diagnostic criteria. the ultrasound diagnostic criteria which is included in Rotterdam is more than equal to 20 follicles. It does not say that necessarily it has to be arranged in a necklace pattern, right? So based on that, I am not saying this is not PCOS, right? PCOS may be ऐसे arrange हो सकता है. It is not necessary that you get a necklace pattern. Clear? Which of the following is an absolute contraindication to OCP use? Now, if you are my student who has written A over here, you are writing A for what? Theca lutein cyst? No, beta, this is ovarian hyperstimulation syndrome. Okay. Now, come to this. Which of the following is an absolute contraindication to OCP use? Now, absolute contraindication ke liye, if you are my student, you know this, that it is the mnemonic is banks have various schemes to provide home loans during May, right? So this is the mnemonic which you have to remember for all absolute contraindications of OCPs. Now remember, diabetes is not per se a contraindication. It is diabetes with vasculopathy which is an absolute contraindication. History of amenorrhea is not a contraindication. Pregnancy is a contraindication. Chronic renal disease is not a contraindication. 26 का answer. What was 26? I don't even know which question. Over here it is ovarian hyperstimulation. Okay. Thromboembolism is an absolute contraindication to OCPs, right? So thromboembolism is an absolute contraindication to OCPs. Absolute contraindication of OCPs, which is also called as WHO category 4, is very, very important for all of you. I want all of you to take a screenshot of these absolute contraindications and keep it with you. This is very, very important. Right? Okay. Then again, another question which is very important, which came in NEET 2021 is how do you manage missed pills? So a female had missed pills on 4 different days in the first 2 weeks of the cycles. What advice are you going to give? So please remember, again, this is something which is shared in the PDFs with you. If one pill is missed, then in that case what you do, you take the, whenever the female is going to remember, she's going to take the missed pill, she's going to resume her schedule and she's not going to take any backup method. That is if one pill is missed. Now if 2 pills are missed in first week or in second week, she is going to take 2 pills daily for 2 days and she's going to take a backup for 7 days and she's going to continue with the pack. Now, if 2 pills are missed in third week, in that case, tell her to stop using that pack now, discard the pack, start a new pack and use backup for 7 days. Same thing you do if 3 or more than 3 pills are missed in any week. If 3 or more than 3 pills are missed, you have to tell the female, stop using this pack now, throw this pack, start a new pack and use a backup for 7 days. Now, in this case, patient has missed 4 pills. So, I am going to tell her to discard the pack, start a new pack and start to use some alternative method of contraception for 7 days. Right? Then, which of the following is an absolute contraindication for insertion of the device? Now, which device is shown over here? This is copper T380A. What is the other name? It is Paragard. Right? And what is an absolute contraindication? Absolute contraindication for copper IUCD. Backup ka matlab hota hai any alternative method of contraception, which could be barrier, which could be anything. Right? Copper IUCD and Mirena ka combined absolute contraindications are current PID, undiagnosed vaginal bleeding, distorted uterine cavity and a suspected pregnancy. So these are absolute contraindications for using both copper IUCD and Mirena. For only copper IUCD, Wilson's disease is an absolute contraindication. For Mirena, if there is history of breast cancer, that's an absolute contraindication. Please remember, previous history of ectopic pregnancy and previous history of PID are not absolute contraindications. So menstruation is not a contraindication. Immediately after delivery is not a contraindication. Ruptured condom during intercourse is not a contraindication. Contraindication is trophoblastic disease, that is a type of pregnancy, and any suspected pregnancy is a contraindication for using copper IUCD. Right? Then, a 24-year-old lactating woman with 18 months of child comes with history of irregular heavy bleeding and seeking contraceptive advice. What is the contraceptive of choice over here? Now, tell me, in this case, what is there? The patient is having irregular heavy bleeding. She has 18 months old child and she has come to you for contraception. Now, anyone who's having heavy bleeding, do we suggest copper T? No, because copper T itself leads to bleeding, right? So, I am not going to suggest copper T, right? Now, as far as progesterone IUCDs are concerned, progesterone IUCDs are very good for a female who has come to you with excessive bleeding and she wants contraceptive also. And the progesterone IUCD which is used these days is Mirena. Progestasert is a progesterone IUCD which is no longer used. So the answer cannot be progestasert. Progestasert is no longer used. Right? Now the option choice is between Mala N and norethistron enanthate. Now first tell me, 18 months में अगर एक female breastfeed कर रही है, can I use OCPs? Yes. Please remember, if a female is breastfeeding, right, you can start OCPs after 6 weeks. Ideal time to start OCPs is after 6 months. If a female is not breastfeeding, you can start OCPs after 3 weeks. Ideal is 6 weeks. Because OCPs की दो problems होती हैं. One, they decrease breast milk. Number two, they can increase the chances of thromboembolism, and already pregnant females में clotting factors काफी high होते हैं. So even if the female is not breastfeeding till 3 weeks after delivery, I do not prefer OCPs. Ideally, in a non-breastfeeding females, you should not use OCPs till 6 weeks, but if you have to start, you may start by 3 weeks. Till 3 weeks, it's absolutely contraindicated. Right? So now this patient has 18 months, that is 1.5-year-old child, and she is breastfeeding. So can I start OCPs? Yes, I can start OCPs. Can I give her norethistron enanthate depot injection? Norethistron enanthate depot injection is progesterone injection. Yes, I can give her progesterone injections. Now, as far as progesterone contraceptives are concerned, progesterone does not lead to any thromboembolism. Progesterone does not decrease breast milk. So all progesterone contraceptives can be used in day one, from day one, in breastfeeding females also and non-breastfeeding females also. The only exception is DMPA. DMPA, if a female is breastfeeding, we avoid DMPA till 4 weeks. Why? Because DMPA की एक problem होती है, it leads to osteoporosis. It decreases bone mineral density. And if a female is breastfeeding, up till 4 weeks, I do not prefer DMPA. Now, because norethistron enanthate is also a progesterone injection, so I am presuming that the problem which is there with DMPA will also be there with NET-N. NET-N is also going to decrease the bone mineral density, and as it is, this female has breastfed her baby for 18 months, which is too much. So I am not going to prefer norethistron enanthate for two reasons. जितने भी progesterone contraceptives होते हैं, they also lead to irregular bleeding. So a complication of these injections is irregular bleeding, and this female already has irregular bleeding. Plus, a complication of progesterone injection is they decrease bone mineral density. And this female has been breastfeeding her child for 18 months, for 1.5 years. So already calcium in her body would be less. So my answer is going to be Mala N. Clear to all of you? Yes? Now quickly just go through this. In this, when I've given you the PDF, I have written that which contraceptive can be started from what time after delivery. This is a very, very important chart. I have made a summary over here and I have posted it on the Telegram group. So go through this. This is very important for all of you. What is the role of ulipristal in emergency contraception? Again, a very theoretical question. This table is given over here. This is with the doses of all emergency contraceptives. Emergency contraceptives is a very, very important topic. The dose of ulipristal is 30 mg. So please remember all the drugs which are used for emergency contraceptives and their dosages, right? And also by which mechanism emergency contraceptives act. The best answer for mechanism of action of emergency contraceptive is that they delay ovulation. Second best answer is that they inhibit implantation. Delay ovulation is the answer, not anovulation, right? So if they ask you by what mechanism emergency contraceptives act, answer it as they delay ovulation. Remember all the drugs which are used for emergency contraceptive along with their dosages. That is very important. Which of the following is not used as emergency contraceptive? Copper T is used, Ru-486, that is mifepristone, is used, and high dose estrogen is used. Danazol is not used as emergency contraceptive, right? Now, in prolapse, a 55-year-old lady presents with third degree uterine prolapse. Which of the following is best management for her? Now, remember, best management in a female who's coming to you with prolapse, who has completed her family, 55 years means she's completed her family, is vaginal hysterectomy and along with pelvic floor repair, which is called as Ward-Mayo's hysterectomy, right? Fothergill's repair should be done in reproductive age females, and those females who do not want any future childbearing. So reproductive age female whose family is complete, you go for Fothergill's repair, right? Sling surgery is reproductive age female who wants future childbearing. For them, the answer is sling surgery. Shirodkar procedure is also for reproductive age females who want future children. But then the best surgery for a female who is reproductive age, who has uterine prolapse and who wants future childbearing, the best answer is sling surgery, not Shirodkar. Shirodkar is also done in them, but then Shirodkar is not the best answer. Now, if your question says that there is a postmenopausal female like this female, 55 years, and she has comorbidities, if they would have given comorbidities like MI or like diabetes, then I wouldn't have been able to do a vaginal hysterectomy because the anesthetist won't have given the anesthesia. So in that case, my answer would have been Lefort's colpoclysis. If the age of the female is she's very elderly, more than 65 years, and she has third degree uterine prolapse, in that case, my answer would be pessary. Similarly, pregnant female or postpartum female with third degree uterine prolapse, the answer is pessary, right? Now comes a very important concept and a very important question on AUB. A 35-year-old female attends gynae OPD with history of excessive bleeding 6 months ago, which is not controlled with non-hormonal drugs. Ultrasound and clinical examination reveal no abnormality. What is the next step? Now, please understand. There are two things. यहाँ पे जो ध्यान देने वाली बात है, the question is saying that she was given non-hormonal drugs and the bleeding is not stopping. So if you have given her non-hormonal drugs like tranexamic acid or mefenamic acid and the bleeding did not stop, first you have to give her hormonal drugs. And so my answer is going to be hormonal drugs. I am going to give her hormonal drugs, and still if the bleeding is not controlled, then I am going to go for endometrial sampling. Right, because यहाँ पे ये word non-hormonal था, so your answer first has to be give her hormonal drugs, try to control her bleeding, and then go for endometrial sampling. Right, now suppose ये non-hormonal drugs ना होता, it was just this, that she was controlled, the bleeding is not controlled with drugs. So you've given her medical treatment and the bleeding is not getting controlled. Then in that case, my answer would have been endometrial sampling. Are you understanding? Because of this word non-hormonal drugs, first I'm going to try hormones, I'm going to try progesterone, I'm going to try OCPs, I'm going to try to control her bleeding, and if her bleeding stops, that doesn't need endometrial sampling because age of the patient is 35 years. Right? In reproductive age females, endometrial sampling should be done only if a female has risk factors for endometrial cancer. That risk factor could be diabetes, obesity, PCOS, or if endometrial thickness is more than equal to 12 millimeters on ultrasound, or if AUB is not responding to medical management, then you have to go for endometrial sampling in reproductive age females, right? So since she's 35 years and question is saying, not telling me that she has PCOS or she's obese or she's diabetic, question is saying ultrasound mein everything is normal. That means ET is normal. Either the question should have said ET is more than equal to 12 millimeters, right? And number 3, AUB not responding to medical management. Over here, non-hormonal drugs diya hai, to pehle hormonal try karo, and still the bleeding is not getting controlled, go to endometrial sampling. This is in contrast. This is in contrast to if the age of the female would have been perimenopausal age group. In India, the recommendations are if age of the female is more than 40, but ACOG says that if age of the female is more than 45, then irrespective of ultrasound findings, if a female is coming to you with excessive bleeding, you have to do endometrial sampling. They try to confuse you. They say that there is a female who's 45 years old, on her ultrasound fibroids were seen, and what is the next step? So she's come to you with AUB, on ultrasound fibroid seen, what is the next step? So you tend to say that I'm going to manage the fibroid. No matter what the findings are on ultrasound, the next step in a 45-year-old female who has come to you with AUB will be endometrial sampling. Clear to all of you? Yes? Now, when in postmenopausal females, what do you do? In postmenopausal females, you are going to do endometrial sampling only if endometrial thickness is more than equal to 4 millimeters. If your question says on ultrasound endometrial thickness is more than equal to 4 millimeters, or if your question says that it is a case of metropathia hemorrhagica. If your question says कि patient को कोई bleeding नहीं हो रही है, she's a postmenopausal female who doesn't have any postmenopausal bleeding. यहाँ पे endometrial thickness more than 4 millimeters is when a patient is coming to you with bleeding. Now, if patient is not coming to you with bleeding, she is a postmenopausal female in whom you did a routine ultrasound and you saw endometrial thickness is more than 11 millimeters. In that case, still you will have to do endometrial sampling. Right? Now, please understand these few things very, very properly. Postmenopausal bleeding करके patient आ रही है, you are going to do endometrial sampling only if endometrial thickness is more than equal to 4 millimeters. Postmenopausal bleeding करके patient आ रही है and there is metropathia hemorrhagica, then you are going to do endometrial sampling. Patient is not coming to you with postmenopausal bleeding. On routine ultrasound, you are seeing that endometrial thickness is more than equal to 11 millimeters. You have to do endometrial sampling. Next thing, Suppose she's a reproductive age female and you gave her, she came to you with excessive bleeding, you gave her hormonal therapy, you gave her medical management, but the bleeding did not respond. I told you next step is endometrial sampling. Now listen to my question very carefully. There is a postmenopausal female who comes to you with postmenopausal bleeding. Her endometrial thickness is less than 4 millimeters. So her endometrial thickness is 2 millimeters. Now just now I told you, if there is a postmenopausal bleeding patient and her endometrial thickness is less than 4 millimeters, you will not do endometrial sampling, right? So अब अगर 2 millimeters है, I am not doing endometrial sampling. What am I going to do to stop her bleeding? I will give her tranexamic acid, because the most common cause of postmenopausal bleeding is atrophic endometrium. So इस patient को bleeding is happening because of atrophic endometrium, right? Now the question says that you gave her tranexamic acid, but the bleeding did not stop. What is the next step? Please do not say the next step is endometrial sampling. I am suspecting endometrial cancer in her, right? क्योंकि less than 4 millimeters है and tranexamic acid देने के बाद भी the bleeding hasn't stopped. So now my next step becomes fractional curettage and hysteroscopy. Clear? Clear to all of you? Yes, endometrial sampling is done to rule out endometrial cancers. You are right. Questions on vaginitis. Treatment of choice for postmenopausal female complaining of vaginal itching and having atrophic vaginitis. Now all of you know that for atrophic vaginitis, यहाँ पे जो options दिए हैं, I'm going to mark the answer as estrogen. Local estrogen or topical estrogen is the management for atrophic vaginitis. The drug of choice is lubricants. Second drug of choice is topical estrogen, and the third drug of choice is ospemifene. Right? Clear to all of you? Remember that all the selective estrogen receptor modulator drugs like clomiphene, like tamoxifen, like raloxifene, all of them, they lead to vaginal dryness. They are not used for treatment of vaginal dryness. There is only one SERM, SERM, which can be used for treating vaginal dryness, and that is ospemifene. Clear? Then next question. A 28-year-old married woman was anxious to conceive. She presents with copious vaginal discharge without any itching. She had her periods 13 days back. What is the cause of her discharge? Please remember, there are three very important characteristics of leukorrhea. That is physiological discharge. Number one, it is colorless. Number two, there is no foul smell. And number three, there is no itching. Right? Where it could be scanty, it could be copious, depending upon in which time of the cycle it is happening. Whether it is happening in the pre-ovulatory phase. If it is happening in pre-ovulatory phase, it will be copious. If it is happening in post-ovulatory phase, it will be scanty. Now, because this vaginal discharge doesn't have any itching, so I am ruling out trichomonas, I am ruling out candidiasis. Candidiasis ke discharge mein there is a lot of itching. Trichomonas ke discharge mein there is a lot of itching. Right? Now, because the question doesn't say that this discharge is foul smelling. Foul smelling कहते तो I would have marked the answer as bacterial vaginosis. In bacterial vaginosis also there is no itching. In physiological discharge also there is no itching. There is only one thing which can differentiate between them, and that is foul smell. Foul smell कहते तो it would have been bacterial vaginosis. Since they have not mentioned foul smell, I am going to mark the answer as physiological. Right? So over here, take a screenshot of this. Various on the basis of various characteristics given, how can you differentiate between discharges? That is very important. Also, it is very important to know syndromic management of discharge. That's also very important. Which kit is being used? It is kit number 2 or green kit, which has got fluconazole 1 tablet 150 mg and secnidazole 1 tablet of 2 grams, right? All this is very important. The color of discharge, foul smelling, itching hai ki nahi hai. Then a sexually active female comes with profuse, frothy, foul smelling discharge with intense itching and strawberry cervix. Now these words, as I told you, I have written it over here also for you. If the discharge is frothy and it is yellowish green in color, it is trichomonas discharge. Then strawberry vagina or strawberry cervix, when they say it is trichomonas discharge, and in trichomonas there is intense itching, so this is trichomonas vaginitis. In trichomonas vaginitis, the drug of choice is metronidazole and partner should be treated because it is sexually transmitted, right? An 18-year-old girl, now this is NEET 2020. An 18-year-old girl comes to gynae OPD with 6 months of amenorrhea, low-grade fever, weight loss, pain in abdomen, generalized weakness. On examination, a pelvic mass is felt and there are features of ascites. What is the diagnosis? So I'm sure you know that the diagnosis is TB pelvis with tubo-ovarian mass. She has come to you with anorexia, weight loss, pain in abdomen, and there is amenorrhea and a pelvic mass is felt. So it has to be genital TB, right? So important points on genital TB. Most common site for genital TB is fallopian tube, ampulla, and the second most common site is endometrium. Most common symptom is infertility. Most common route is hematogenous. Genital TB is a secondary infection. Most common primary site being lung followed by lymph node. Most common menstrual irregularity which you see in genital TB is polymenorrhea followed by secondary amenorrhea. Most common pelvic finding which you get in genital TB patient is normal. You will not get anything, a normal pelvis. Second most common pelvic finding is an adnexal tenderness. But if genital TB is happening in adolescent girls, then a bilateral adnexal mass is the most common pelvic finding. If it is happening in reproductive age females, pelvis is normal, right? But if it is happening in adolescent girls, then the most common pelvic finding which you get is a bilateral adnexal mass. For diagnosing genital TB, you do pre-endometrial biopsy in the premenstrual phase. Management of genital TB is you have to give ATT for 6 months. Management of infertility in a TB patient is you have to go for IVF. HSG is contraindicated in genital TB patients, right? While discharging a patient who underwent vesicovaginal fistula, which of the following would you recommend? Please remember, after you have repaired VVF, there are certain post-operative instructions which you have to give. You have to do continuous bladder drainage and you have to give antibiotics for 2 weeks. You have to tell them for having abstinence, no intercourse, no per speculum examination, no per vaginal examination for 3 months. Ideally, it should be 3 to 6 months, but at least 3 months. And pregnancy is contraindicated for 1 year. Right? And if whenever a patient of VVF conceives, then the management is the delivery has to be done by cesarean section. So over here you have to tell them that they have to undergo a sexual abstinence for 3 months and they have to avoid pregnancy for 1 year. Very straightforward question. You have to remember these post-operative advices. Right? Now, a 56-year-old woman with grade 2 or grade 3 uterine prolapse and cystocele complains of passing urine on coughing and sneezing. All of you know that whenever a patient is passing involuntary urine on coughing or sneezing, that means whenever intra-abdominal pressure is increased, that is what is called as stress incontinence. And stress incontinence may be seen along with prolapse. Prolapse के patients में there can be stress incontinence, right? Okay, tell me what is the best management, best surgery for stress incontinence? Best surgery for stress incontinence is Bursch-Kolpo suspension. But what is the most commonly done surgery? Most commonly done surgery is TOT, that is tension-free transobturator tape, followed by TVT, that is tension-free transvaginal tape. right? Some miscellaneous topics over here. A 28-year-old female comes with history of fatigability and constipation. She has history of multiple blood transfusions after her delivery, which was 4 years back. She has lactation failure and she has never had her periods. So this patient is a case of secondary amenorrhea, plus there is failure of lactation, plus she has easy fatigability, plus she has history of repeated transfusions after her delivery. That means she suffered from PPH and now she is having amenorrhea and lactation failure is there. So she is a case of Sheehan syndrome, right? Next, Mrs. Rekha. She has a child 2 years of age, presents to her family obstetrician with complaint of pruritus vulva and amenorrhea. She has history of severe blood loss and failure of lactation during pregnancy. She is lethargic and has cold intolerance. All this is happening because of hypothyroidism. She has got multiple skin infections and anemia. What is the diagnosis? It is Sheehan syndrome. So in Sheehan syndrome, there is necrosis of the anterior pituitary gland. The first hormone to decrease is LH and FSH, followed by growth hormone, prolactin, ACTH, and the last hormone to decrease is TSH. A patient of Sheehan syndrome will come to you with secondary amenorrhea, failure to lactate, loss of pubic hair and axillary hair, and hypothyroidism, right? What is the first line treatment of osteoporosis in postmenopausal female? The first line treatment for osteoporosis is bisphosphonates. Second line treatment is HRT. Are you going to give HRT? If uterus is present, you are going to give estrogen plus progesterone. If uterus is absent, you are going to give only estrogen. Then you can use raloxifene for treating osteoporosis, but raloxifene can never be used for treating hot flashes because its side effect is hot flashes. Then what are the drugs which act on osteoblast? There are only two drugs which act on osteoblast. One is teriparatide, another one is strontium ranelate, right? How do you diagnose osteoporosis? You do it by DEXA scan. You are going to measure the bone mineral density. And what is the indication for doing bone mineral density? In all females who are more than equal to 65 years of age, you have to do a DEXA scan to measure the bone mineral density. Or if the female is more than equal to 60 years and she has risk factors like rheumatoid arthritis or she is using heparin, then from 60 years onwards you have to do a DEXA scan or you have to measure the bone mineral density. Remnants of Wolffian duct are present in. Now, Wolffian duct, when it regresses in females, it leaves remnants. These remnants are epophoron, paraophoron, and Gartner's duct, and they are present in broad ligament. Whereas remnants of Mullerian duct are present in males, and these remnants are prostatic utricle and appendix of testes. Clear to all of you? Yes? So I think there is some lag in the internet. Okay. Next question, which of the following is not estrogen dependent pubertal change? So which is not an estrogen dependent pubertal change? Very straightforward question, hair growth. For hair growth, the hormone which is responsible is androgens, right? For breast development and for closure of epiphysis, it is estrogen. Now I just want you to remember two things. You don't have to remember Tanner and complete Tanner staging. Just remember that whenever breast budding is present, it means it is Tanner stage 2. And in which stage of Tanner hair is present on mons pubis? In Tanner stage 3, right? Breast budding present indicates Tanner stage 2 and Tanner stage 3 में mons pubis में the pubic hair are going to appear on mons pubis. Right? This is what I want you to remember in Tanner stage 2 and Tanner stage 3. Then comes a very important question. A mother brings her 16-year-old daughter to gynae OPD with complaints of not attaining menarche, right? So she's a case of primary amenorrhea. Definition of primary amenorrhea is very, very important. She gives history of cyclical pain in abdomen. On further examination, a midline abdominal swelling is present. On per rectal examination, a bulging mass is present in vagina. Please remember, in a virgin female, per vaginal examination is contraindicated. So if I want to see whether uterus is present or not, I have to do a per rectal examination. Ab yahan pe patient has come to you with primary amenorrhea, and when you did a per rectal examination, a mass was present in vagina, a mass could be felt, and that means it's a bulky uterus which you are feeling. There is blood which is present in vagina, and there is blood which is present in uterus. Right? So that means her uterus is present. Now, because her uterus is present, it cannot be a case of MRKH, Mayer-Rokitansky Custer-Hauser syndrome. MRKH means Mullerian agenesis, and in Mullerian agenesis, uterus is absent. Right? Now, what is this midline abdominal swelling? This midline abdominal swelling is blood-filled uterus, that is hematometra. This means this patient is having menstruation, but the menstrual blood is unable to come out, right? So it means she's a case of cryptomenorrhea. Now, cryptomenorrhea के तीन बहुत important causes होते हैं: imperforate hymen, transverse vaginal septum, and vaginal agenesis. All these three are causes of cryptomenorrhea. In cryptomenorrhea, patient is going to give you history of cyclical pain in abdomen, which is present over here. The most common cause of cryptomenorrhea is imperforate hymen. In case of imperforate hymen, when you are going to do a local examination, there will be tensed blue hymen which will be present. In case of transverse vaginal septum, you will not get any tensed blue hymen. And in case of imperforate hymen, when you ask a patient to cough, cough impulse will be present. In case of transverse vaginal septum, cough impulse will be absent. Right? These are the ways in which you differentiate between imperforate hymen and transverse vaginal septum. In case of vaginal agenesis, you will not see any vaginal opening. Vaginal opening ही absent होगी. The other, now, out of these three, which am I going to choose in this case? I am going to choose imperforate hymen because that is the most common cause of cryptomenorrhea. A very important thing which you should remember about vaginal agenesis is that vaginal agenesis is usually associated with Mullerian agenesis. So generally in patients of vaginal agenesis, uterus is also absent, right? So in this case, I am going to make my choice as imperforate hymen, which is the investigation which can differentiate transverse vaginal septum and imperforate hymen MRI. But you will never need an MRI because clinically also they can be differentiated based on local examination and based on cough impulse. Right? Okay. Now, next question. A 13-year-old child visits gynae OPD with complaints that she has not attained menarche and her karyotype is 46XX. On examination, clitoromegaly is present. Now, whenever there is 46XX individual who's having clitoromegaly, this means that the female is getting exposed to excessive androgens. And the most common reason for a female child, 46XX child, getting exposed to excessive androgen is congenital adrenal hyperplasia. In congenital adrenal hyperplasia, you have to remember कौन सी enzyme deficiency can lead to manifestation in 46XX karyotype and which enzyme deficiencies can lead to manifestation in 46XY karyotype and which enzyme deficiencies can lead to manifestation in both 46XX and 46XY karyotype, right? So enzyme deficiency which leads to manifestations in 46XX karyotype, the most common is 21 alpha hydroxylase deficiency. The second most common is 11 beta hydroxylase deficiency. In 46XY karyotype, The enzyme deficiencies which can lead to manifestations are the enzymes which start with number 17. That is 1720 lyase and 17 alpha hydroxylase. And the one which can affect both 46XX and 46XY are 3 beta HSD and P450OR enzyme deficiency. P450OR stands for oxidoreductase enzyme. Right, so this can lead to both. In both it can lead to a problem, right? So over here the answer is going to be 21 alpha hydroxylase. Please remember 17 alpha hydroxylase leads to problem in 46XY karyotype. 3 beta can lead to problem in both. 11 beta leads to problem in 46XX, but it is less common than 21 alpha hydroxylase. Right? Now, what is the screening test for congenital adrenal hyperplasia? The screening test for congenital adrenal hyperplasia is you have to check the levels of 17 hydroxyprogesterone. If 17 hydroxyprogesterone levels are less than 200 nanograms, that rules out congenital adrenal hyperplasia. If levels are between 200 to 800, then it may be congenital adrenal hyperplasia. You will have to do a diagnostic test, that is ACTH stimulation test. And if values are more than 800, then that is diagnostic of congenital adrenal hyperplasia. Right? So all these enzyme deficiencies you have to remember. Never say 17 alpha, because 17 jahan par aata hai, that means it is 46XY karyotype ko wo affect karta hai. 46XX ko only two enzymes, one is 21 alpha and another is 17 and another is 11 beta. Right? 3 beta HSD and P450 can affect both of them. The distension media which is used in hysteroscopy with bipolar cautery is. Now I want all of you to answer first with bipolar cautery and then with monopolar cautery also I will ask this question. Now quickly understand one thing. जब भी आप hysteroscopy करते हो, whenever you do hysteroscopy, you can use electrolyte rich media or you can use electrolyte deficient media. Electrolyte rich media is ringer lactate and normal saline. Electrolyte deficient media which you can use is glycine, sorbitol or mannitol. Now let us understand what is the difference between the two. Electrolyte rich media can be used only with bipolar instruments. It cannot be used with monopolar instruments, because if you use it with monopolar instruments, it will lead to shock and it will lead to burns. Right? So bipolar के साथ you can use both electrolyte rich and electrolyte deficient. Monopolar के साथ you can use only electrolyte deficient. Now comes if with bipolar I can use both, which one should I choose? I should choose electrolyte rich media. Why? Because electrolyte deficient media will have certain specific complications. For example, water intoxication. Water intoxication is a problem which can happen only with electrolyte deficient media. Then number two, it can lead to hyponatremia, because most of the electrolyte deficient media are hypoosmolar, so they lead to hyponatremia. Right? Except mannitol. Mannitol is isoosmolar. It does not lead to hyponatremia, but most of the other electrolyte deficient media, they lead to hyponatremia. That is why if I am using bipolar instruments, I have to choose between electrolyte rich and electrolyte deficient media, I should choose electrolyte rich media. Right? So in this case, when I have to choose and they have asked with bipolar cautery, I am going to choose electrolyte rich media. I am going to choose normal saline. If the question would have been monopolar cautery, then I would have chosen the answer as glycine. Right? Now, when you are doing hysteroscopy, you use a distension media. In electrolyte rich media, you use normal saline or ringer lactate. In electrolyte deficient media, you use glycine or mannitol. And you have to be very vigilant that how much fluid has gone in and how much is coming out. Now, whatever fluid goes in and whatever is coming out, there will be some difference in them. So suppose I have given the fluid 1 liter and only 500 ml is coming out. This means 500 ml has been absorbed by the patient's body. So there is a deficit of 500 ml. Now, a question is asked that when should you stop hysteroscopy? What is the deficit at which, fluid deficit at which you should stop doing hysteroscopy? In case of electrolyte rich media, if there is a fluid deficit of 2.5 liters, in other words 2.5 liters of fluid has been absorbed by the patient's body, then you should stop hysteroscopy. In case of electrolyte deficient media, because it leads to water intoxication, you should stop the procedure as soon as there is 1 liter fluid deficit. Clear? This also was a question which was asked in your INI set exam. Now, 2 questions on cancer cervix, and that completes your discussion for today. A 52-year-old woman diagnosed with cancer cervix stage 2B was advised radiotherapy. Which of the following statements regarding radiotherapy is false? Now, they are talking about point A and point B. Now, when you do radiotherapy, there are 2 points, point A and point B. Point A is 2 centimeters above and 2 centimeters lateral to the internal os. So, if this is the internal os, point A is 2 centimeters above and 2 centimeters lateral to the internal os. Point B is 2 centimeters above and 5 centimeters lateral to the internal os. That means the distance between point A and point B is 3 centimeters. Right? Point A is the place where paracervical or parametrial lymph nodes are present, and the amount of radiation which goes at point A is 7,000 to 8,000 centigrades. Whereas at point B is the position where obturator lymph nodes are located, and the amount of radiation which goes there is 6,000 centigrades. Right? So over here, point B is 3 centimeters lateral to point A. Yes. Point A receives 7,000 centigrades. Yes. Point B receives 6,000 centigrades. Yes. Right. Point A is 2 centimeters above the external os and 5 centimeters lateral. No, it is 3 centimeters lateral. It is 2 centimeters lateral to internal os. So this option was the incorrect option. Right? Which of the following is the causative organism for vulval warts? So all of you know that HPV is the causative organism for vulval warts, and which HPV? HPV 6 and HPV 11. That is the causative organism for vulval warts. Now what is, if I ask you, what is the drug of choice for treating vulval warts during pregnancy? It is TCA, trichloroacetic acid. That is the drug of choice for treating vulval warts during pregnancy. The last thing which I want you to revise quickly is cancer cervix management. Now please remember, in cancer cervix, in stage 1A, 1B, in 1B, in 1B1 and 1B2, and in stage 2A1 you do surgery. In stage 1B3, in stage 2A2, and from stage 2B to stage 4, you have to go for chemoradiation. Right? Now, in chemoradiation, you are going to give cisplatin first, followed by radiotherapy. Right? So, what are the stages where you have to give chemoradiation? 1B3, 2A2, and then from 2B to stage 4. You have to give chemoradiation. Other than that, all stages, the initial stages, you have to do surgery. Right? Clear? So, that is all for today, and that completes your PYQs. All your PYQs are done. Please keep revising all the subjects PYQs. PYQs of all subjects are important because they help you in knowing what topics are important. Right? So please revise PYQs of all topics. I will again come with you live on 13th of Feb, where I am going to tell you discussions related to important topics. Some important topics I am going to take up in the form of discussion. Right? So your entire last minute revision of OBG consists of 3 parts. So if you are a marrow subscriber, what you are going to do, you are going to do this PYQ session, you are going to do the revision videos which I have given you for edition 6, and you are going to do MCQ discussion. That is going to complete your preparation for NEET PG Obs and Gynae. If you are not a marrow subscriber, again you have to do 3 things. You have to watch this PYQ session, you have to watch the next session which I'm going to take on 13th Feb. You have to watch the image based session which I'm going to take for you, I think on 20th or 21st of Feb I'm taking that session. And all of you, it's a request that please all of you watch the update session which I have given before INI set on my YouTube channel. The link for that session I'm going to post in the comment box. Please watch that session, that has got all updates. This video is going to remain on YouTube, don't worry about that. Okay. So take care, all the best, bye bye.